And we're live.
All right, good morning. This is Senate Health and Welfare, and it is February 12th. This morning, we're looking at S27, the medical debt bill. Then we're also continuing to work looking at medical records and bringing in folks to talk about that a little bit and what's happening in the state for the Vermont program on quality health care. And then we're hearing from folks from the various organizations in the state. So we're starting with S27. And before we do that, I think everybody knows everyone, so we don't need to introduce ourselves. I will say that Senator Hart is on Zoom, getting over a cold. Senator Douglas is either on his way or may show up on Zoom, but the rest of us are here. This is what
do either.
Huh?
Senator too sick to do either.
Yeah, we don't know. Well, he was getting much better yesterday, so let's hope that he.
Yes, Zoom problems.
Yeah, I did.
That's true.
Surprise.
We're working.
I know you are. You're doing a good job. So, Jen, why don't you come up and then I'll talk briefly about the bill and why I introduced it.
Okay.
And then we'll go through the bill section by section. This is our first look at the medical debt bill. Obviously, there's been a lot of discussion about it. And anything that we can do to reduce the pressure on people and families and patients from the kind of the oppressive costs right now of healthcare, anything we can do is helpful. So the bill, from my perspective, I'm not going to go through it in depth, but I'm going to say that it allows for the treasurer. The treasurer is going to help us understand where the money comes from, but by investing $1 million in a company, will be able to put aside $100 million of debt, medical debt, and take the burden off of people. So I think the biggest thing that happens is a huge relief and from anxiety and pressure to be responsible for medical debt that may be overwhelming. And so we're going to hear about that. And there's an income level for people who are eligible for the program. It'll be 400% of poverty or lower. And the other real benefit is that it takes the medical debt off of credit rating reports for individuals. So be able to breathe a sigh of relief and perhaps live their lives in a way that they hadn't been able to with that credit rating being under that burden. So that's kind of the general look at the bill. Our committee is working on the cost of healthcare, looking at ways that we can reduce those costs and improve access. And I think this falls into the category of reducing some of the burden that people face. Jen, I'll let you go through the bill.
Okay, great. Good morning. Jennifer Garvey from the Office of Legislative Counsel. Put the bill up on the screen. This is S27, sponsored by many members of this committee. And this is an act relating to medical debt relief and excluding medical debt from credit reports. It starts off with a section appropriating $1 million to the state treasurer from the general fund in fiscal year 2026 for the purpose of contracting with a nonprofit entity to acquire and repay certain medical debts incurred by Vermont residents as set forth in this section. It requires the treasurer to ensure that the entity with which the treasurer contracts will purchase the medical debt of eligible debtors from healthcare providers at fair market value, will abolish the debt with no cost or tax consequences for the debtor, and will coordinate with the healthcare provider or collections agency to ensure that any adverse information resulting from the medical debt is removed from the debtor's consumer credit report following the contractor's purchase and abolition of the debt. In order to be eligible for repayment of medical debt under the section, there's two conditions that must be met. The debtor must be a Vermont resident who either has a household income that is at or below 400% of the federal poverty level for the applicable household size, or owes medical debt in an amount that is 5% or more of the debtor's household income. And the debtor's patient account still maintains an outstanding balance even after the healthcare provider has completed its routine efforts to collect the amounts. So people who either have a lower level of income or a higher level of debt compared to their income, and even after the provider has tried to collect the debt, it has not been successful. Section 2 provides that $1 million that is appropriated to the treasurer by reducing by $1 million the amount appropriated to the treasurer's office for redeeming state of Vermont general obligation bonds prior to maturity. Section 3 adds a provision to the consumer protection statutes that prohibits a credit reporting agency from reporting or maintaining in a file on a consumer information relating to medical debt. And that definition of medical debt is taken from the patient financial assistance provisions in Title 18. Sections 4 and 5 actually both relate to some disclosures that are required to be made to consumers about credit reporting under Vermont law. And anytime a credit reporting agency is going to, there are certain circumstances under which they're required to make a written disclosure to consumers about the prohibition on anyone accessing their credit report without their permission, except in certain limited circumstances. And this would add a new limited circumstance where the request for a credit report is by an organization that is exempt from taxation under Section 501c3 of the Internal Revenue Code, so a 501c3 nonprofit organization, for the purpose of determining eligibility for the abolition of medical debt. I think the treasurer's office may talk to you more about this, but this allows the kind of soft pull of credit. Section 5, so Section 4 was about the disclosure to consumers and adding that exemption to the otherwise broad prohibition on pulls on credit. Section 5 actually adds that exemption. So the provisions of the disclosure requirement do not apply to an organization that is exempt from taxation under Section 501c3 of the Internal Revenue Code when determining eligibility for the abolition of medical debt. So they are able to do their soft pulls. Section 6 is amending this chapter on patient financial assistance that I mentioned earlier, where the definition of medical debt resides. And this is adding to that subchapter title and medical debt. And in that existing chapter, the subchapter, there is a section prohibiting the sale of medical debt. This would add a prohibition on the reporting of medical debt. And also make some changes in that section. So under current law, no large healthcare facility, which under the definitions there is in that subchapter, is a hospital or ambulatory surgical center or other very large facility. So no large healthcare facility shall sell its medical debt, and this would add except as provided in subdivision 2 of this subsection. And this says a large healthcare facility may sell or otherwise transfer its medical debt to a 501c3 tax exempt organization for the specific purpose of that organization abolishing the medical debt of one or more patients by cancellation of the indebtedness. So in general, no sale of medical debt by these large facilities, but they can sell it to a nonprofit that is going to cancel the debt. And then this adds a new provision prohibiting a large healthcare facility or medical debt collector from reporting or otherwise furnishing any portion of a medical debt to a credit reporting agency. This is now sort of a state analog to what has recently happened at the federal level, but regardless of what happens at the federal level, it would maintain the prohibition in Vermont law. And the act would take effect on July 1st at the beginning of fiscal year 2026.
Okay, questions for Jen? I think a lot of our questions are going to be for the treasurer.
I imagine so.
Good, good. We stop here for a minute. Good. Okay, thank you. Treasurer Pichek, welcome.
Great.
I think this is the first time you've been in this committee, is it?
At least
Did
as
you?
treasurer, certainly.
This one. Treasurer. Oh,
Yeah.
that's true. That's great. Thanks for coming in.
Yeah, of course. Yeah, nice to see everybody. Good morning.
Yeah. So, there are a lot of questions that we would have for you and maybe I think, the funding piece, the organization that's purchasing the debt, and thinking about how it's administered, some of
Yeah,
these
for sure.
things. Yeah. So why don't you go ahead and wait, do you know everyone around the table? We're good with that.
I do.
I think you know Senator Cummings
Yes.
really well. And Senator Hart up on the screen.
Yes.
Okay, good. We're all set. That's good.
Well, for the record, Mike Pichak, State Treasurer. We do have a presentation that runs through a lot of the questions that that the chair has. So,
Hello. We have it. We can get it out and we'll look at it.
Is he putting it up?
I think we're working on that.
Yeah.
So, just the overview of the sort of beginning part of the presentation sort of talks about the issue of medical debt and the problem of medical debt generally, and then specifically in Vermont. Then goes through a little background and history about undue medical debt, this entity that in all likelihood is who we would partner with. They're the sort of the prominent and pretty much only not-for-profit that is in this space doing this kind of work, and they've been partnering with a lot of other government organizations. And then there's a description about how it would work in terms of the relationship with the hospitals and actually purchasing medical debt. And then we'll discuss a little bit about how the operations would work in our office, and then the source of the $1 million that is requested as part of this program.
So we talked a little bit about that yesterday in
Oh, yeah.
appropriations, but I think it'll be good to have that
Yeah, for sure.
discussion here as well.
So on this issue of medical debt, I think it's just important to put in the context of this committee well knows that medical debt is different from other types of consumer debt. It's something that often happens to somebody. And when it's happening to the person because of a medical crisis, they don't have the option to forego the care, unlike when you're making a major purchase with a home or a car or some other kind of purchase, maybe going to school or something like that. And there's really no option or opportunity when you're in that health crisis to shop around for different rates or different, within network, out of network, and all those kind of issues. So it's something that largely happens to people. And oftentimes people, and Vermonters are this way as well, just don't have a lot of savings to buffer the cost of medical care that is unexpected. That's again, something that happens to them rather than them proactively going and seeking some sort of consumer debt. And then in Vermont, and this is a national trend, obviously, as you know, deductibles are larger and larger. So even though we have a high insured population, we have a high uninsured population or underinsured population, which can leave somebody sort of one medical episode away from falling into medical debt. So medical debt is recognized as a social determinant of health, particularly relative to economic stability of an individual and sort of determining their health, a non-health related item that can impact their health related outcome. It's the leading cause of bankruptcy in the United States, and it's more prevalent in communities of color. And as we made the point in Vermont, folks that are lower wage earners, folks that have lower median income are going to disproportionately be impacted by medical debt and will likewise be disproportionately impacted in a beneficial way from this program because it focuses on those that have moderate and low income. And then this point here, and this is backed up by an analysis by the Vermont Department of Health, but even if a provider has stopped the collection attempts, so the patient remembers and often avoids care for fear of medical debt. And there was a report by the Vermont Department of Health that said 85,000 Vermonters, an estimate, but 85,000 Vermonters reported concern around seeking medical care because they're worried about going into medical debt. So in terms of this pervasiveness of medical debt, there's an estimate that 4 in 10 adults nationally have some sort of medical debt. Here in Vermont, we might have a slightly better percentage. There's a lot of different ways that a lot of different organizations have calculated medical debt. But we estimate that with this program, there's over 60,000 people that would be eligible for medical debt relief. And then there's even more than that are carrying medical debt here in Vermont. In terms of undue medical debt, they used to be called RIP Medical Debt, but they are a nonprofit and they're really focused on this issue of erasing financially burdensome medical debt. They've been around for about a decade, founded in 2014. One of their former founders was a debt collection executive or a team of debt collection executives. And like I mentioned, it's really the leading organization, if not one of the only organizations that is in this space. Now, they started out in 2014 as a charitable organization. They raised money and they received money from foundations. They sought grants, and then they would go out and negotiate with hospitals across the country and eliminate medical debt. So over their history for the last decade, they've eliminated about $15 billion in medical debt for just about 10 million people in the United States. In this most recent year, just about $3 billion of debt relieved. And since 2018, about $500 million of debt relieved in the Northeast. So I mentioned that because they have a long track record of doing this. They have a long track record of doing this across the country, getting the results that we anticipate here in terms of that 100-to-1 ratio. And they are really the reputable organization, nonprofit in this space. They received an $80 million grant from Mackenzie Scott in 2020 that really helped them propel their work forward. And through those philanthropic efforts on the next slide, they actually had some Vermonters whose debt was purchased. So there have been some Vermonters who have been impacted by their work purely through the philanthropic previous work that they've done across the country. And they happen to be in Vermont. But you can see these two testimonials, one from Bobby in Richford, who says, I received a letter in the mail about my medical bill saying that debt abolishment was generally provided by Principal Financial Foundations. That was the entity that donated the money and coordinated by Undue Medical Debt. I was shocked and it touched my heart. I have truly been blessed. I was trying to figure out how I was going to pay my outstanding medical bills. Angel in disguise. And then Emily from Burlington says, I can't believe my medical debt is abolished. I racked up this debt when I had a medical or mental health crisis. They put me in an ambulance, didn't properly charge my insurance, and I racked up a $9,000 bill. I was too sick to even deal with it. I ended up refusing to pay it because it was their mistake. I almost couldn't buy a house because of collections, having my debt abolished. Only a few weeks before giving birth, just had my first baby, Stella. It was amazing. Cannot thank you enough. So just a couple of testimonials from people that have been touched in Vermont already by this program. And now we're trying to sort of, like a number of other jurisdictions, focus their work in Vermont to try to have this impact more broadly. So touching on a couple of other states and jurisdictions that have done the same, Connecticut has partnered with Undue Medical Debt. They've appropriated $5.5 million to cancel an estimated $650 million in medical debt for 250,000 residents. Rhode Island, their treasurer's office is coordinating this work in Rhode Island. The treasurer, James Diosa, was up for the press conference a few weeks ago. Rhode Island's appropriated $1 million to medical debt forgiveness. Preliminarily estimates the program will help 30,000 state residents pay off $85 million in medical debt. So they have had a positive experience to date. They're sort of in the moment where they've already passed the legislation. They're in a contract with Undue Medical Debt. Undue Medical Debt has started negotiating with their hospitals, and they started to pay down some of that medical debt already. And
I was just going to say the treasurer has volunteered to testify.
Yes.
We may ask him to do that.
Yeah, for sure. Yeah, it'd be great to hear how things are going there. Just a couple of other states, New Jersey, Arizona, the District of Columbia. Again, all of them anticipating basically this 100-to-1 ratio. Arizona is the largest to date. They appropriated $30 million to cancel $2 billion of medical debt. Pennsylvania, Illinois, and then there's some local efforts as well. Maybe we should just say New York City mayor, not specifically which mayor it is, but New York City Mayor Eric Adams has announced a plan in New York, Philadelphia, Cook County, Illinois was the first. They're on here as one of the organizations, but Cook County, Illinois was the first government entity to think about partnering with Undue Medical Debt during the pandemic. So they had the concept, and then it's obviously taken off with other large counties, other cities, and then other states across the country as well. In terms of undue medical debt, who is their typical provider? Because this was a question that was important to the hospitals when we met with them, because the hospitals would say, well, we're nonprofit. We don't sell debt. We don't sue or report credit. Always, I can't say it for every hospital, but larger ones said that. We have solid financial assistance programs. And undue medical debts, that's basically our typical provider that has all of those characteristics. So the characteristics that Vermont hospitals have are their typical provider. And their point is that it's not the provider that is doing something wrong. It's not that's not the point. It's that there are gaps in the healthcare system in the United States that people fall into and end up with medical debt. So there's a quote here from the president of the University of Chicago Health System talking about the benefit of medical debt and how it goes beyond financial relief. Patients wanting to have the peace of mind to ensure they don't delay or entirely avoid seeking important medical care. They need to stay healthy. This removes an important psychological barrier, which in turn extends the organization's ongoing health equity work and patient care mission. So it's great to see that kind of support in other states from the medical healthcare community, that they view it not just as a financial program, but as a program that helps people access healthcare and builds health equity into their communities. So the way that this would work from a hospital standpoint, let me just back up. If we were to pass this legislation, we would probably do a simplified bid process to work with undue medical debt, given that there's really uniquely positioned to do this. Once we had a contract with them, we would help introduce them, orient them to Vermont providers, and then they would really take the lead. They are the ones doing the administrative work of the negotiation. And then once the medical debt's purchased, they're also doing the administrative work of sending out notices to the individuals to let them know that the medical debt has been eliminated. So Undue is doing that administrative work. They generally will invoice for whatever, they'll invoice over time, little by little, as they buy the debt and eliminate it. And with whatever amount they are purchasing and eliminating, they generally charge 10% for their own administrative fees, which has been pretty consistent in all the other jurisdictions. So that's helpful to us in the treasurer's office. We don't anticipate needing additional staff. We'll have to certainly manage that relationship and that contract, and we'll have to help them navigate the Vermont provider scene. But they're the ones doing the negotiation and handling the communication with individual Vermonters. So once they're in a position to negotiate with the hospital, they'll enter into a non-disclosure agreement, some sort of business agreement that allows them to share the medical debt file. They'll be sent the medical debt file. Undue will analyze it. We talked about this soft credit inquiry so that they can determine who qualifies as an individual based on income limits or that sort of extreme amount of debt eligibility that they have.
Can I ask a question about that? So, so the determination for eligibility will be self-reporting. How's that or is that going to go through so sometimes hospitals obviously have financial support systems and understand who's, income levels. So how?
Yeah, they may very well be in the debt file some information about income levels, but that's where the soft credit inquiry comes into play, where they undue medical debt, can sort of test eligibility by, engaging in that practice and understanding the individual's income and medical debt that might be listed and outstanding for their 400% of poverty threshold and also their 5% of income threshold.
So it won't go to the extent of, it will be more either self-reporting or hospital reporting.
Yeah. And third-party
verification.
So once Undue has sort of analyzed the debt files and said, here's who is eligible and who we want to purchase the debt. And generally, again, I think we mentioned, but the debt is generally 18 months old to 7 years old. That's sort of the range. So that's the other thing that they'll be looking for eligibility. And then they'll get to a amount, they'll get to a dollar amount. Some hospitals across the country have said that when they get to that amount, they will sometimes donate it instead of actually purchase, depending on the financial situation of the hospital and their interest in the program and what other programs they might have going on. Some have dedicated toward patient assistance, the monies that the hospital receives. So those are conversations we've had here in Vermont, and some hospitals seem interested in that as well. So we'll have to see how that develops. But overall, generally from Undu's perspective, they say that it's a positive impact on the hospital's financials in all cases because there's such limited economic value in this debt at this point, even though the individual Vermonter sees the entire face value of what they owe to the healthcare provider. So the next page is just sort of a visual of how that works. I think we can, if anybody has any questions, happy to answer, but I'll just skip to the next slide if not. A couple of quotes here from different hospital systems that have gone through this process in other states, describing it as a win-win, very positive experience working with Undu Medical Debt, forgiving so much patient debt for financially vulnerable patients, highlighted to our organization that we really do need to live our values in providing great patient care and supporting our community. The whole team was really inspired by this partnership, and similar quotes from other hospital CEOs. And then this last slide here, and then happy to answer any questions, but talking about specifically the impact here in Vermont. So Undu has estimated that they could eliminate up to $100 million of this older medical debt for moderate and low income Vermonters. I think their estimate is that in Vermont, there's around 150 million, maybe 155 million of outstanding medical debt. So they estimate that 100 million would fall into this category, both in terms of that 18-month to 7 years, that sort of post-collection period, and also that from an eligibility standpoint, the individual's a moderate or low income individual, again, tested by 400% of poverty or lower. Prohibits the reporting of medical debt on an individual's credit report. So we put this in, even though there was a federal prohibition that the Biden administration had announced and implemented right at the end of their term. Now that's overseen by the Consumer Financial Protection Bureau, which has, which is sort of under fire from the administration. So even before the recent events of the last couple of weeks, we thought it would be prudent to put a similar prohibition in Vermont law in case the federal law went away. We're certainly open to making sure the Vermont law mimics the federal law so that it's not sort of a disruption or an additional requirement. Now the CFPB, the future of it is uncertain, but when they issued the medical prohibition on medical debt on an individual's credit report, they did expressly say that they encourage states to sort of follow their lead or even go further than what they were doing. So now, of course, that was a different administration, different CFPB, but we think it's wise practice to at least enshrine what the Biden administration had done on this issue here in Vermont. And then it requires a one-time $1 million appropriation. Now that appropriation could be less, it could be more, depending on how the negotiations go, how much medical debt they determine is actually eligible. If it's less than 100 million, if it's more than 100 million, if a hospital decides they'll donate the medical debt instead of, it being a exchange of cash. So, some flexibility there over time, but the estimate is that it'll be a one-time appropriation, maybe needing less over time, but having the one-time appropriation would sort of make sure that we could pay what is estimated across Vermont. We have this recommendation of reallocating $1 million from a pot of money that had been appropriated to us about 4 years ago. In total, we had appropriated to us about $20 million to buy down outstanding bonds. This was sort of, I wasn't here at the time in this role, but my understanding is it was sort of thought of as we had extra money at the time. Why not pay this? Why not make an extra payment on our debt? So we've gone to market and issued bonds twice since that time, 2023, 2024. And we've looked at, what would happen if we purchased $20 million of bonds and retired them early. And we didn't execute in either case because we were able to refinance older bonds that we otherwise would have paid. And we were able to achieve some significant savings. I think in 2023, it was $1.3 million in savings. In 2024, it was $3.7 million, about 5 million. So we're able to achieve sort of refinancing savings over time without buying down the debt completely. We have about 600 million outstanding in bonds, so 20 million is a relatively small number. And while we were waiting sort of to do that analysis, we also were earning significant amount of money on the 20 million. Every year we were earning about $50,000 on that, or sorry, $1 million on that money, 50,000 for each million. And the estimate is that if you bought down the bonds with the full 20 million, it would have a one-time impact of $1 million in savings. So, putting that all together, we just hadn't been executing on this money. We sort of were leaving it there, and it was hard for us to imagine buying down the bonds in the near future because we were earning so much more than, the specific intended purpose of the legislature gave us the money for. So we kind of, raised our hand on the 1 million and said, we think this would have a more immediate and a similar sort of outsized impact, $1 million to retire $100 million of medical debt. And then there have been discussions about the other 19 million that don't involve this program. But generally, if there's needs that are more immediate, we are open to having that conversation with the rest of the money as well.
Good. So, yeah, no, I think that what you're saying actually makes sense to me. If you're earning more by not using that $20 million, then we should do that. And then this is an additional use for $1 million.
Yeah.
An investment in people.
Yeah, that's exactly right.
Yeah. So, I think questions.
Yeah, for
You
sure.
ready for questions?
Yes, absolutely.
Yeah, okay, so, I want to go to, I'm going to start out, you talk a little bit about the administration of this. And so as it's first oversight, your office will be providing oversight to ensure that it goes along smoothly and it's money well spent.
Yeah.
The question, you've answered somewhat the question on how to determine eligibility. That from the quotes we're seeing from the patients who have benefited, it sounds like everything happens over here and they know nothing about it until it actually happens. And so it would depend on data that's available within the hospital system. And then hospitals voluntarily participate in this or not? You're shaking your head, yes. So I'm just going through trying to get all the little questions that I had. And then where does money exchange hands?
Yeah. So
That'll be my final question. I think it's
yeah, for sure.
Senator Gulick has questions and I want to keep her.
Well, just one thing just to highlight in your question about the individual sort of getting a letter, sort of this letter out of the blue. We like that aspect of the program because it's sort of universal eligibility for people that meet those qualifications. So there's no application process. And I think that's good for two reasons. One, it reduces the administrative cost of, but the other is that, we've administered programs at DFR during the pandemic, or even in unclaimed property. We had a program last year where we were automatically returning money to people, this money back program. And whether people are coming and applying for something, like we administered the hazard grant program, people could get $2,000, with pretty minimal requirements. And I think there was an aspect of that where we had to individually go out to individuals. We texted them, we emailed them, we sent them letters, we even called them. And I think we got like 65% of the eligible universe that applied. And this unclaimed property program, we sent out 5,000 letters and then eventually checks. And I think we have 70% of people that have cashed their checks. So, there's just this element of not everybody gets included.
Responds.
Yeah.
Yeah.
So this is automatic. You get the notification, you get the letter, the impacts are felt, immediately once that happens. Hospitals do voluntarily participate. It's why we've been engaging the hospitals, both the larger hospitals like the UVM Health Network and also VAS and all the individual hospitals. Other providers can participate too, but most medical debt we think is going to be held with the hospitals. And they, I'll let them speak for themselves. We've had really productive discussions with all of the hospitals in Vermont. And then your question about when does the money change hands? It's that moment when, they'll have to decide which hospitals they want to engage with first or how many at one time. They get the debt file, they do their eligibility, and then they make an offer to the hospital. We'll buy these 10,000 files for, $53,000. And, then if there's a negotiation or if there's not, the hospital agrees. And then they'll send us an invoice and say, we have purchased $53,000. We purchased, this amount of debt for this many Vermonters, and plus a 10% administrative cost. We would approve the invoice, send them the money out of our trust fund, and then we would work with them on actually sending letters and other communication to individual Vermonters to make sure they know that this debt has been abolished and forgiven.
Okay, and then undue debt is paying the hospital the $53,000. Yeah. Okay, good. Yeah, I mean, as you're talking, I'm thinking that some of these patients will be so sick that they don't have time or energy to do what's needed for medical debt.
For sure. I mean, that
Can't work.
just that one example that we read. I mean, I think that will be a common example. Somebody that was experiencing a health crisis or mental health crisis, and they just weren't in a position to fight whatever determination was made. And then, years go by and you sort of, it's just something that constantly you're worrying about, but you're putting off dealing with, and then
Gets put. Yeah, let's go ahead, Senator.
Thank you, Treasurer Pichek, for being here. This is a fascinating topic for sure. And I will get on my soapbox for a second just to say that in most countries, there's no such thing as medical debt because healthcare is a public good. Same with education. It seems particularly pernicious to put people in debt who are trying to get smart and get healthy. But that aside, I am a co-sponsor of the bill and I really like the bill. And I also am doing my due diligence. I heard from some of my constituents who wanted me to ask you a few questions, and some of the things I'm doing. There was an article in one of our Vermont papers talking about this issue, and I think that probably sparked some questions for folks. Particularly, some of my constituents, claim that the medical debt that is being proposed to, and you've touched on a lot of these things, being is not deemed collectible at this point. Taxpayers, they're worried that this $1 million will be going to executive bonuses, which is something that's been in the news and people are concerned about. And that, I heard things like medical debt is already taken out of most FICO scores, not usually determined to determine a person's credit worthiness. So things like that are causing a little bit of angst in some folks. I was just wondering if you could speak to that at all.
Yeah, for sure.
Which you already did, but.
So on the, on the piece about the economic value of it, it is true that there's marginal economic value of this debt, and that's why you can purchase it at 100 to 1. But, that's looking at it from the hospital perspective. You look at it from the individual patient perspective, they still see the 100% face value of what they owe the hospital. And that's what's driving their anxiety and their worry and their decision not to seek care, forego medical care, and those things that we talked about, with the health department survey and the undue medical debts experience. And then in terms of the impact on the credit score, it depends. Some providers report to a credit rating agency, others do not. If they report to a credit rating agency, there's some debt that is not reported, like if it's under $500, that's a decision that the credit bureaus have made. But if it's over $500, certain banks or credit unions may put it in a different category than other debt, but it still exists. And even if it's not as part of the FICO score, it's still something that could contribute to the overall financial picture of a credit, of credit being dispensed or not being dispensed. So even if it's not impacting your FICO score, it could impact your access to credit. So that's sort of both the point around the forgiveness and the prohibition on, prohibition on the credit reporting to begin with. The point about hospital bonuses, the way that this will work is it's reimbursement for debt, sort of piecemeal, little over time. So there's no windfall to the hospital, but also the hospitals, and I don't want to speak for them, but again, some that have been in the news have suggested, well, maybe there's an opportunity to specifically earmark funds that are received under this program for additional patient assistance. So those are ongoing conversations. They have to make that decision. That's not part of this program, but the conversations have not been, this is how we'll direct money to pay for administrative expenses in our hospitals. And how can we sort of double down and help patients even more, which has been a good productive conversation to have.
So, thank you.
Yeah.
Okay. Any other questions? Okay, good. Thank you.
Yeah.
It's been really great. Very helpful. And what's even more helpful is that you brought this issue to us and we greatly appreciate it.
Well, we appreciate the partnership with the committee and with you, Chair Lyons, and look forward to working with you. And if you need any help in terms of folks to testify or, ideas around who to testify, please feel free to reach out to our office. I should mention that Ashton Doyon is here with me, our Director of Policy, and Becky Wasserman, our Director of Economic Empowerment, who would manage the program.
Oh, good. And we know some of these people. Yeah, they got stolen,
Well,
but not
there's free will.
really.
There's free
So,
will.
yeah, it's great. Thank you.
Yeah, thank you.
Appreciate it.
Thank
And we will reach out, if we go forward, we might have some further requests.
Great. Thank you very much.
All right, good. So we're, Ernie Davis is here. Did you want to offer
Yes.
some comments from Leukemia and Lymphoma Society?
Thank you for the opportunity to testify today. Yes, Ernie Davis, Senior Director of State Government Affairs for Leukemia and Lymphoma Society. We're pleased to submit testimony to the Vermont Senate Committee on Health and Welfare supporting Senate Bill 27. At LLS, our mission is to cure blood cancers and improve the quality of life of patients and their families. LLS exists to find cures, ensure treatment access, and improve survivorship for blood cancer patients. The average cost in the first year of treatment for a blood cancer patient averages $470,000. LLS last October released a poll that stated over 90% of U.S. adults agree that elected officials should pass policies that protect people with serious illnesses like cancer from medical debt and harassment from collection agencies. LLS is leading or part of coalitions working on medical debt legislation in dozens of states nationwide, specifically in many of the northeastern states, Rhode Island, Massachusetts, Maine, Connecticut, New Jersey, New York, and Pennsylvania. And those are all states that I've actually worked on medical debt legislation in. So certainly happy to answer any questions about experiences or anything in regards to those issues. And as the treasurer talked a lot about, the Consumer Finance Protection Bureau recently released a report and determined that medical debt is the #1 reason for individual bankruptcy. And I know, Madam Chair, as we talked about before the meeting started, I think certainly the work in the states is that much more important based upon what may or may not happen with the CFPB. Medical debt, I think it's very important to point out, is a debt that's not a willing choice and is sometimes made under the duress of the choice of life or death. And it's widely accepted to have the most mistakes due to lack of notification, billing errors, coding errors, and difficulty in appealing. This often inaccurate medical debt is reported on credit bureaus begins the downward spiral of negative consequences in securing future employment, housing, and other credit opportunities that affect generations. Just 2 weeks ago, the CFPB urged several states across the country to continue passing medical debt policies at the state level, most notably the prohibition of reporting medical debt to credit bureaus, which is contained in this bill. When patients can afford their medical treatment, health outcomes improve. We urge the committee to pass Senate Bill 27, and I'm happy to answer any questions you may have.
Thank you. Questions? I'm very familiar with your organization, and my daughter ran a marathon on behalf of an individual with leukemia and
Well, thank
belong
her.
to the society. Yeah.
Thank you for her doing that. And,
He raised a lot of money. I think that was great.
well, and that's part of, what I do. I often joke that like I'm trying to lobby myself out of a job. So someday we cure blood cancer and I have to go look for a job someplace else.
That
So,
would be terrific if you. would do
Absolutely.
that. Thank you.
well, thank you for the opportunity to testify.
Yeah, thank you very much. And we're moving on. Francie Whalen, who is Public and Policy Government Relations PRA Group. So online, there you
Hi.
are. Welcome.
Thank you. Thanks so much for having me. Chairwoman Lyons, members of the committee, my name is Francie Wayland. I'm the Vice President of Government Relations and Public Policy at PRA Group, Inc. I'm here today because we have some concerns with SB 27 and its interplay with existing law. We support the overall aim of the bill, which is to help relieve the burden of medical debt on Vermont consumers.
Oh, can you hold pause for a minute? Is there a question? So you can't hear?
Just who is PRA?
Oh, thank you. Yes, can you
Sure.
define PRA?
Yes, PRA is a publicly traded company headquartered in Norfolk, Virginia, that by and through its subsidiaries purchases portfolios of consumer receivables from major banks. Interestingly, PRA does not purchase medical debts. It's mostly credit cards. And that's part of our concern that we wanted to bring to the committee today, because Vermont S27 essentially says no reporting on medical debt. And our concern is that in 2022, Vermont, as it does a lot, is on the cutting edge of a lot of these issues that come up before the state legislatures. And in 2022, when you first looked at this issue, it was in the context of patient financial affordability related to hospital policy. Medical debt was defined as a debt arising from the receipt of healthcare services. And then healthcare services was defined as services for the diagnosis, prevention, treatment, cure, or relief of a physical, dental, behavioral, or mental health condition or substance abuse disorder, including procedures, products, devices, or medications. So when you put those terms together, the definition really is quite broad and could conceivably pull into the bill's coverage the entire balance of any garden variety credit card that was used to pay, for example, for a copay from a hospital visit, a flu shot at Walgreens, or a massage at the local day spa. And then suddenly, with one medical debt charge, that entire balance of the credit card is looped into the bill's protection from credit reporting. So companies such as ours that are just lawfully kind of going about our business practices are suddenly in violation because we don't know that there's a charge for medical debt, and thus the entire balance on the credit card is now deemed medical debt and protected from reporting. I would love to offer what we think is an elegant solution going forward. The Biden-Harris administration, CFPB, recently finalized their proposals on medical debt. And they're focusing on the definition of medical debt and really define it in terms of to whom the debt is owed, which, by the way, I think nicely kind of flows with your proposal from Undo Medical, where they're, going to the hospitals and medical providers and pulling debt from there. The CFPB's rule, which was finalized January 7th, adopted a definition, and I'll read that to you. Medical debt information means medical information that pertains to a debt owed by a consumer to a person whose primary business is providing medical services, products, or devices to such person's agent or assignee for the provision of such medical services, products, or devices. Medical debt information includes, but is not limited to, medical bills that are not past due or that have been paid. And to us, the CFPB absolutely nailed it. And that's no wonder that they did, because they have a team of economists and attorneys who looked at this issue and researched it for more than 3 years. In their rulemaking process, that's further informed by public input. There were numerous field hearings on this, consumer roundtables, comments from industry participants and stakeholders back and forth. And most importantly, when proposing rules, the CFPB assesses the benefits and the cost of the regulation that they're considering for consumers as well as financial institutions. That we feel like the CFPB here has taken an academic, very well-researched approach to this issue and more narrowly tailors that definition essentially to debts that are owed to a medical service provider. And not unsurprisingly, the next state that took up this issue, California, opted to adopt the CFPB's definition in their bill, doing the same thing, prohibiting the reporting of medical debt to credit reports, but they pulled that definition in word for word. So we would urge the committee to consider the CFPB's definition. Think that this is a very important issue, and are here to be helpful in any way that we can. Thank you.
Thank you very much. I guess I want to go back to that. We'll consider your testimony certainly and look at it both with the treasurer and our legal counsel. But I guess my question is, who do you represent? It was a question that was asked earlier. Who is it that's in your group that you represent?
Right.
Who funds your organization?
Well, PRA Group Incorporated is a publicly traded company. I work for PRA Group, and we're a purchaser of consumer receivables headquartered in Norfolk, Virginia, traded on NASDAQ. We have offices in 12 countries across the world, but again, are headquartered down in Norfolk, Virginia. Our trade association is RMAI, which is the Receivables Management Association International.
Okay.
They're a collection agency.
A collection agency? No.
No, we're actually purchasers of debt.
For credit card debt.
Yeah, we purchase those portfolios of the credit cards, mostly credit cards, and then we work with our customers to help them repay their obligations and hopefully working down the road to financial recovery.
Okay, and your concern is that if people put their medical debt on their credit card,
Yes.
that it could interfere in your book of business or, okay.
Correct. And I think it makes sense, right? Because I think that the goal of the bill here is to protect the consumers from what we would generally, I think, all traditionally call medical debt, hospitals, the big bills, like when you do get sick. And I don't think what we're trying to do is protect consumers from medical debt, from massages or spa days that we think could accidentally fall under the definition as it's written, just because it's a little bit too broad.
Okay, thank you. We appreciate your time and information, and we have your letter with us so we can look. And I know you have a representative in the room, so we can connect with you guys. Thank you very much.
Thank you for having me.
All right. So the committee on our agenda, we're reversing process here. We have a consultant from UMass and I guess Harvard as well, Nancy. No. Anyway, as we looked at the bill yesterday, or the framework for our healthcare reform bill, one of the things that we talked about were audits and how audits might work, in particular around hospitals. And I know that the concern about hospital networks is an issue. And so I
This is a new topic, right?
Yeah, we're shifting gears, but I
Okay.
wanted to let folks know who have come in from
Whoa,
VPQHC
it's still
that
unfinished.
at 10 o'clock, we're listening to Nancy Kane, who is talking with us about audits, and you're welcome to stay in for that if you'd like. It's going to take a little while, so, if you may. I think it's gonna take about an hour, so just to let you know that, and then we'll come back to, talk about, could be less, it'll go for far. But you can, welcome to stay, and as you would like, and then we will move on to the BPQHC because it's important to us. What we're hearing about now, and have a seat if you'd like, what we're moving on to now is, hearing from an expert in, auditing, Nancy Kane, who will introduce herself in just a minute. And so one of the questions that came up yesterday was, and that has come up repeatedly, both in the media and in our work and here, is the value of having an audit for individual hospital budgets, particularly when networks with out-of-state hospitals are involved, so like UVM Health Network or others, and trying to understand the flow of funds and what that means to Vermonters and the benefit to Vermonters that we might see. So, and Nancy, I don't see, do you have a slide deck that you're going to share with
Yeah.
us? Okay.
Yes,
all
I
right.
do. Yeah, I do. And I'm going to see if I can share it right now so that I don't screw up. Sharing is not turned on, so I guess I have to wait till someone turns me on.
So while Kiki will turn sharing on for you, and while she's doing that, it would be great if you might introduce yourself for the record and share with us who you are. And just before we do that, we're going to share with you who we are. And so we're going to start with Senator Cummings over here. Yeah, we got it up here.
I'm Ann Cummings. I represent Washington District, which is the state capital and surrounding county. And I chair the Senate Finance Committee, which is also responsible for health insurance.
Yes, it is. And so Senator Gulick has just stepped out. She represents part of Chittenden County. Senator Hart is on Zoom along with you. He represents Orange County and other related areas. And Senator Douglas has been out ill, and he represents Essex, Orleans County. And I am Senator Jenny Lyons, and I represent Chittenden Southeast, and you and I had a terrific conversation the other day, so it's good to meet you in person, sort of in person. So now please introduce yourself to the record.
Thanks. Thanks, Senator Lyons. I'm Nancy Kane. I'm a professor emerita from Harvard T.H. Chan School of Public Health, and have worked as a consultant to the Vermont Legal Aid Group. So for the last couple of years to help review some of the budget requests, particularly the ones from the University of Vermont Health Network Medical Center and the system. So
I will just say that is the fact that you were working with legal aid is something that I learned when you and I started talking. So it's good to know there's a connection.
So, I will try to share my presentation. I'm not sure I know what I'm doing.
Okay.
Because I retired right before COVID, so I didn't have to learn all these.
We have it on our computers, but it would be great to have it up on screen if you could.
Let's see if let's see if this works. Share. Seems to be loading. This may take a little bit of time.
Yeah.
Send, I guess. I don't know. Nope. I don't want to add people. Well, is it showing at all?
Not yet.
Okay.
Now it is.
Okay, here we go.
You gotta
Oops.
do.
Is it showing for you?
Now you've got a launch meeting, the show launch meeting.
She should be able to just click the screen she wants to show.
Click the screen that you want to show.
I've lost it. I don't see it anymore. I'm screen sharing. Okay.
Adobe PDF at the bottom, the red square on the bottom bar right there.
That's not it.
Okay. Is it one of the tabs you have open next to them? One of those two blue ones?
No, it's here. I'll put it back on. I had it on. Ah, see, I had it on for a minute. It's right there.
Here it comes.
Is
There
that
you go.
showing?
Yeah, now just click full screen. Get rid of the.
Yeah.
Yeah,
Okay.
perfect.
Good,
Good job.
Magical. Now you can see I'm still, even though it's been years, I still can't quite do all this. So I'm just going to talk. I'm not an auditor, just so you know. I have a background in financial analysis in healthcare, and I think in some ways that might be more what you're after than an audit. So let me talk a little bit about my expertise, what I learned, and what I suggest you think about as you consider how to use financial information for your very totally valid public policy making purposes. So here's my background. I'm professor of health policy and management emerita. I've taught financial accounting and payment and strategy, many courses for 40 years at the school. I have an MBA and a doctorate from the Harvard Business School. My first job was in Massachusetts rate setting in 1976. So just that gives you some sense of how long with the battle for figuring out how to control hospital healthcare costs, particularly hospital costs, have gone on. That job, by the way, is going to be relevant to what you're trying to understand. I think my assignment was to define the reasonable financial requirements of hospitals. And this is now 50 years later, and we still can't define them.
Still arguing about it.
And it's partly because everybody says, let's look at the profit margin, but that's really not the key thing. Really the types of things that hospitals need that aren't shown even in our operating expenses and their income statement are their need for capital, for existing buildings, for new technology, for information systems, Epic and Workday, their need for insurance reserves. If they have a Medicare Advantage plan or a risk-based commercial plan, they need to create reserves. They need capital to repay debt. And they need profit cash flow to repay debt. And they also use their profits to build what I call liquidity resiliency, which is a large cash balance to help them, cash and investments, to help them deal with bad years. So that reasonable financial requirement piece is really almost impossible to define with a specific number. It really takes into account a lot of other ambitions and strategies that health systems might want to finance. One of my doctoral students years ago tried to do an analysis of how much cash is enough for the nonprofits, and it turned out that the answer was infinite. So there's a lot of really it comes down to, as a public policy maker, you've got to decide what other concerns come into play in deciding what's reasonable. And there's no magic number to tell you that. So, and I say you need to decide what's affordable as the magic number, and then don't try to second guess how the health systems get there. That's my basic philosophy. So that's my background. I've been doing that kind of work with health systems, with the states and the federal government. I was on the Medicare Payment Advisory Commission for 6 years. I'm on the board of UMass Health System, so I understand, the health systems issues and struggles, and what UMass faces is very similar to what every health system faces, including a University of Vermont. So I'm not against hospitals, but I think I have a deep appreciation for the affordability of the health system and what it does to consumers when they can't afford their health care or avoid care or get a bill they can't pay. So that's where I'm coming from.
So, Nancy, the question, we have a question from Senator Gulick. I have a general question. Do you want to be interrupted during your presentation, or would you like to wait till the end? I guess that's my question, but Senator Gulick has a specific question.
Yeah, I'll dive in. Thank you very much, Chair Lyons. I'm interested in the list that you gave around hospital, costs and not necessarily being a question of profit margin. The one in particular that you mentioned, liquidity resiliency, I think is really interesting. And I'm wondering, as someone who doesn't, I knock on wood, I haven't had a lot of experience in hospitals, which is a good thing. But what makes a bad year for a hospital? You mentioned that it's important to have that resiliency for bad years.
Yeah. Well, you'll see in some of the data I'm going to show you, but for instance, 2022 was a terrible year for almost every health system in the country because we were recovering from COVID. We had 20% of our nurses disappeared, our workforce disappeared for a variety of good and not so good reasons. Supply costs went way up. It was just we often had to close services because we didn't have the staff the manpower to staff the
So
services.
barring a global pandemic.
I'm sorry, I can't hear you. That was a bad year anyway.
So barring a global pandemic, what would a bad year be? Is it just when we're like in an inflationary period?
No, inflation isn't necessarily the critical piece. Individual health systems can have really bad years for just poor management decisions would be my number one reason. Bad strategic outcomes, like Tufts Medical Center in Massachusetts had a bad time implementing Epic and couldn't collect their revenues for a long period. And that really hurt them. And they're still recovering. Oh, I was afraid he was going to come by here. Sorry.
So why don't we let you go ahead with your presentation, but then you've heard the initial questions. I think would be helpful to us going through to try and get.
Let me go on. There's a lot of background noise here. I'm sorry. He'll be gone in a minute.
Good. It's very good.
Can you hear me okay?
Yes.
Okay. So let me help. There's a lot of misunderstanding about financial data. My specialty is what they call financial accounting, which is what systems and organizations report to the outside world. Hang on 1 minute. I'm going to tell them to go away. Just a second. I can't hear.
That's funny. We can't hear it at all.
What's going on?
She must have background noise.
We have what we have outside the door.
That's right. Sometimes we have it bad.
The enforcer has to go up. Yeah.
Wasn't very successful yesterday.
No,
They just kept it. No, they didn't even.
Sorry, that was the leaf blower. It's just,
Oh, that does make noise. They have leaves?
They must be
I'm
somewhere.
in Florida. Yeah, they do have leaves.
Oh, okay.
Yeah. So let me just overall explain that financial accounting is what organizations report to the outside world. The data is audited. For nonprofits, it's very important to get that data out for your creditors, not your investors, but because you don't have any, but you have creditors. And if you misrepresent your financial statements to a creditor, you can be sued. So it's pretty credible data. It's not always easy to read, but it's a credible data. A lot of what you care about, a lot of what people talk about is cost accounting data, which is what the internal data the hospitals use to understand their cost for a particular type of service or unit of production, like how much does it cost to produce a lab test. That's cost accounting data. The Medicare cost report is kind of the most widely available cost accounting system. Every organization may have its own cost accounting system as well. And a lot of the efficiency questions you might be asking have to be looked at from the point of view of cost accounting data, not financial data. So I just want to make that distinction, because when you start talking about audits, you need to know which type of cost you're looking at, cost of financial data you're looking at. What financial data is very helpful for is looking at financial implications of any rate decision. Who should I put caps on their commercial rates on? Which systems should have Medicaid rate enhancements? Those kinds of questions. It helps understand financial impact of strategic decisions made by healthcare systems. When they acquired that hospital and said they were going to integrate, how did that affect their financial health? It also helps you identify financially advantaged or very wealthy systems versus sustainable systems versus distressed systems. And so you can change, you may need to customize some of your cost control types of strategies based on the condition of the system. It does not tell you whether the health system is efficient or not. It does not tell you the profitability of a specific service like obstetrics or surgical services. And it does not give you just one metric to tell you that they're healthy or not, which people wish they did. I get called all the time saying, please just tell me the one number, and there isn't one. So I'm going to show you a little bit about that so that you have some understanding of what the financial data can tell you, the financial accounting data can tell you, and what it cannot in some level of detail. And in my 50 years of experience in using financial data, here's the challenges. The number one challenge is most people don't understand and never learned financial accounting, financial literacy. And that can include analysts as well as the target audience. The other thing that happens in healthcare is there's a proliferation of entities involved in any financial unit of analysis. And for instance, in Vermont, you've got the University of Vermont Health System, the health network, which includes several hospitals and physicians and home health and other entities, or you have just the hospital. Which one do you want to look at? And which one is the financial data organized around? So that's an important consideration. The timeliness of audited financials, they're annual. They do offer quarterly unaudited data, which can be very useful, and creditors like to see that, but it's not, daily. It's not going to something you can sort of say, how did, we just did this, what's going to happen tomorrow? Another challenge is saying, well, how are they doing relative to others? And then there's what metrics to use, who do we compare them to, what are our standards of judgment? And I'll give you examples of that. And then there's this issue of standardized versus customized analyses. So let me give you some examples. I wrote an article a couple of years ago, which you're welcome to. I'll send you a link if you're really you really want to learn this stuff, which most people don't. I noticed a lot of people left the room when I started talking about.
No, it wasn't you. It was the issue. There was another issue. There was another issue in the room. You got a good group here listening.
Great. So, but a lot of people would leave the room if they see what I'm going to talk about. So there's 4 basic areas of financial metrics or financial analysis. And those 4 capture basically, you can get a really good idea of how a health system is doing using these 4 areas. The first area is profitability, which is most often measured by either the total margin, which includes the investment gains in a health system. They have all those cash and investments. And then there's the operating margin, which is basically how well are they doing on the delivery of patient care and their other core activities. And the accounting system has very distinct ways to break those up. Not all hospitals and systems honor the breakup, but an analyst can go in and standardize that. So profitability is one set of metrics. Liquidity is another. How many days of cash do they have in their cash and investments, unrestricted cash and investments portfolio? How long could they run with no revenue collection? You may remember the Change Health disaster. There's a software company that bills for hundreds of hospitals and they got hacked and no one could collect the revenues for a month. You need some liquidity to survive that problem because you got to still meet payroll. So that's days cash on hand. And then just the absolute amount of cash and investments. Those are 2 good measures of liquidity. And as I mentioned before, resiliency. And I'll come back to that. Then there's solvency. How much debt do you have? What's the debt burden, which is that long-term debt to total capitalization, or you could add other types of debt. And then how easy is it for you to repay them, either with your cash, which is not a great way to do it, or with your earnings from operations, which is called the debt service coverage ratio. So those long-term debt, pension, cash and investments to long-term debt, and debt service are all solvency metrics to help say how much debt do they have in the long-term sense. Can they repay it with the cash and cash flow they have for just the doing business? The last 2 are much longer term in nature, but they have to do with the adequacy of capital expenditures. There's a really rough measure called the average age of plant, which has its pluses and minuses, but it gives you a rough comparison if you're comparing one system to another. And then a capital expenditure over depreciation expense. So depreciation is an annual amortization of your capital costs or write-offs of your capital costs. Every asset, every building, every piece of equipment has a useful life, and you take the capital cost of that and divide it over its useful life, and that's basically depreciation. One question, how are you replacing that as you use it up? Or are you accumulating the reserves to replace that as you use it up? So those are the four measures: profitability, liquidity, solvency, and capital adequacy, adequacy of capital spending. And there are ways to look at that, and I'm going to show you a few in a minute. Are there any? Let me just act now. Have I gone too fast? Are people
No, it's
following me
great.
okay?
This is good.
Okay. Okay, so how do we decide whether some health system, any particular one, is doing well or not? One is a peer group comparison, which I'm going to come to it again, but like how do they do with like systems or like hospitals? There's expert judgment, which I've done for years with different parties to help just, a bunch of us who are very financially literate will say that guy's distressed, this one's sustainable, that one's weak. The rating agencies have credit rating criteria that you can look at for an investment grade bond rating. Now, I will say that when you look at rating agency numbers, you're only looking at the group of health systems that have achieved ratings, which leaves out all the poor ones because they can't get access to credit. They're backed by the county or the state or somebody else. And then there's a statewide average. You can look at, how they're doing relative to everybody else in the state. That last one, the statewide average, is kind of not going to work in Vermont because, as you can see from the next slide, University of Vermont Health Network, got that HN, sorry, is almost 70% of all the activity, and comparing it to the other 8 is pretty useless because they're much smaller. But you can do a peer group. So I did this. This is me doing it as a convenience sample. I've got all these hospitals in my data set. I've got a bunch of others too, but I picked the ones in the Northeast or New York that seems similar enough to get a sense of, let's compare UVM Health Network against these other 5 hospitals, health system, academic medical center systems. These are systems, they're multi-hospital systems. And I'm going to show you what that looks like, just so you can see what it can do for you. You can argue whether those are the right guys or not, but it just shows you what a peer group analysis can do. So let's start with just the payer mix. So you probably all realize commercial rates is the golden goose. Commercial payers are the golden goose. Medicare pays roughly cost or a little below cost, and Medicaid is not a good payer. Under the Affordable Care Act since 2010, well, 2014 when it got implemented, we've put more and more and more and more Americans into Medicaid, and many of them were in commercial. So we've gradually moved a lot of people, especially small group and individual, from commercial to Medicaid, and that's had implications for the health system financial viability. But in any case, you can see that this orange bar is UVM Health Network. They're very strong on commercial compared to this. Oopsie, come back. Help. Where you go? Here it is. MGB, Mass General Brigham, which is always off the charts. And then UVM, stop it. Why is it jumping? And then Northwell has pretty good commercial. Maine Health is not bad. Anything over 40% is quite good, usually. Tufts is a little over 40%, but Tufts has other problems. And then UMass, where I'm on the board, is a little below 40%. So we're a little below when you get over 40%, you actually have, it depends on how much Medicaid you have, but you actually have a good shot at being financially sustainable. Medicare, everybody, this is sort of a cost payer relative to the others. Commercial is usually 200 to 300% of Medicare. Medicare is, let's say, 100% of Medicare. And then you got Medicaid, which is usually somewhere between 60 and 80% of Medicare. And you can see that UVM is one of the lowest. Their payer mix is low. Relative to their peer group. So are there questions about this? Because the slide keeps jumping. Can you understand that? So UVM, high commercial, low Medicaid relative to the peer group. So you would expect it financially to probably be a little bit better off than some of the others. So this slide is a mess, but if you look at the red line, that's UVM Health Network's operating margin compared to their peer networks. And I removed the sale of assets from all of the systems. So for instance, UMass sold off a huge specialty pharmacy equity investment for $800 million. And that obviously throws off their margin. So I took that out, and Boston, actually, a lot of these guys are selling assets here and there. So you can see that UVM Health Network by 2023, I'm afraid to do this because it seems by 2023, they're right in the pack. of the healthier ones. Tufts, by the way, actually Tufts is this guy. Their real margin is down here, but it threw the graph off, so I left it at neutral. Tufts lost 17%, had a 17% negative operating margin in 2022. That's a bad year, by the way. And 2022 was not good for most of the systems. This one goes way down because of the labor shortage, the supply inflation, and the fact that capital market, your investment portfolios, although that would be shown more in total margin, they lost a lot of value. So then the total margin, which does include investments, the realized gains on investments, but not the unrealized, also shows a lot of volatility because you've got realized gains in there from the capital market. But by 2023,
Why
UVM is around zero.
so out of line there?
The line for UVM is this one.
Yeah,
Well, the question was, why is UVM out of line with others?
Well, keep in mind, I'm leaving off unrealized gains and losses, which is the biggest number. So this is just their interest in dividend income. And they have much more packed into their unrealized gains and losses than some of these other systems, but they all have quite a bit. This is probably the one that this line is how well they're doing on their core business operations. This line says, let's add back investment income and pension expense. Those are the two big ones, investment income and pension expense.
Wait, can you say that over again? There was some noise in the room.
Okay, so the operating margin is how well they're doing on their core business, net patient revenue, research grants, research costs, those things. This is their core outcome. Total margins include basically two big things: realized investment income like dividends, interest, and realized gains and losses. And it also includes the other biggest thing is usually a pension adjustment, a pension expense. So they're doing worse. If I put in unrealized gains and losses, they would be doing much better. So again, that's one where I can go into a lot of detail, but it gives you some idea of the relative profitability. And I would say if you look at the operating margin, they're doing okay, not great, but they're not doing worse than everybody in their peer group. And in the total margin, they're not doing as well, but you can actually put back in unrealized gains and they're doing great. Does everybody know what an unrealized gain is?
No.
Okay, so it's a change in the value of your investment portfolio. So if you're sitting on $1 billion of cash and investments, the accounting profession the accounting standards allow you to say, well, did the market go up? If it did, that's a gain. And did the market go down? If it did, that's a loss, even though you're not selling your investments. It's just so you think about your retirement portfolio. And if you want to drive yourself crazy, you keep an eye on its value every day. It goes up and down. You're not cashing in on it, but that's a value change. And that gets put into the statements for the unrealized gains and losses. That's why I take it out, because it's so volatile. Liquidity. So to go back to this, cash and investments gives you some resiliency. I'm afraid to use this button, but here's UVM Health Network. Somewhere a little about 125, 130 days cash on hand by 2023, hovering between 100 and something and almost 180. And they're very similar to UMass. Tufts was doing okay until I told you they lost a lot of money. They've starting losing money in 22 and 23, and they had to hit their cash reserves. MGB, nobody can really meet them except Children's Hospital of Boston. Maine Health is similar. Northwell is actually a little low on their liquidity. They're a little overextended. And then the Fitch median of all those nice, healthy, credit-worthy hospitals is around 200 days. So relative to their peer group, UVM is kind of in the ballpark. By 2024, I just got their statements a couple weeks ago. They're up to 153 days. So they're back up above what their target was. And I'll show you some other things about UVM in a minute. But you can see, and then this is the absolute amount of dollars in thousands. And UVM's absolute amount is around $1 billion, as is University of Massachusetts. Tufts drops because of their problems with Epic and other operational challenges. MGB is, what is that, 14 billion, 15 billion, down to 10 billion now. Maine Health is similar to the other guys, and Northwell has actually a decent amount of cash, but it's a very large system, so their days are down. Again, this is just showing what a peer group can say, but I mean, what you look at that, you say, well, they're doing okay considering that others are doing about the same and they're sustainable. How much debt do they have? This is going to solvency, and you can see the UVM, and it actually gets better in 2024, but they're running around 30–40% long-term debt to total capitalization, which is a pretty good number. And you can see Tufts, which is the hospital that's now I think got downgraded to below investment grade, has way too much debt, Get relative to their total capital, their equity and debt combined. And then you can also see that Tufts can't meet their debt service from their operating cash flows. They had to use their cash reserves. Ability to repay your debt, they're all above 1, except Tufts. But MGB's is a little close that year, but it goes back up. And these guys are all very healthy. If it's over 2, you're really doing well. I mean, that's your ability to pay your mortgage out of your operating cash flow. If that makes sense to you. And then the adequacy of capital spending. This is plant age, and you can see, UVM is around 10 to 12 years old. UMass is a little less, starting in 2023 because we just added a new wing. Tufts is quite old, and they also have too much debt. So that's a big sign. If you have old plant and a high debt and not enough profit, that's a big problem. So that's why Tufts is in trouble. MGB always has young plant, and Northwell has very young plant. Maine Health is in the 12 to 13-year-old. And then this is how much have they spent over the last 5 years relative to what they've been writing off. And UVM's a little low. It goes up in 2024, but this is a 5-year average. UMass is also below 1. In other words, if you're below 1 or around 1 even, you're not really replacing what you're using up over that 5 years. Whereas Tufts spent, even though they're really old, they're spending way more than they've used up, and so is Maine Health, and so is Northwell. So that's a sense of the peer grouping. And I'll stop for a minute. Any questions about the peer grouping information?
Oh, it's really helpful. Good.
You can see how it does start to give you a sort of a top line picture of what's going on and how bad it is, or good it is.
Judging.
Am I okay to go on? That's a little hard to hear.
Yeah.
Okay, and then I wanted to show you that was all about the UVMH and the health network, the system, which is everybody. But you can see these 2 columns show your UVM system versus UVM medical center. And in almost every metric, the medical center, if it was standalone, does better than the system. Except in the days cash on hand. And that's because the parent has half the days cash on hand. It redistributes it, but that's where it's reported on the consolidating schedules. So, when UVM came in for the rate hearing in 2023 and said, well, in 2024, and said our days cash on hand is below 150, I'd say, yeah, but that's because the system's holding half the cash. And I'll show you something else about that one too. But, they say, oh, we're poor because we don't have 150 days cash on hand. And going, but you're in a system that has a lot of cash. So that's the entity issue. Who do you want to regulate? Who do you want to look at? And I kind of think you have to look at both to get a sense of what's going on. And then the long-term debt to total capitalization, they have less debt than the system overall. So the medical center is healthier than the system as a whole financially. And then we come to UVM Health Network investments in New York hospitals. And I know it's a contentious issue, and I don't want to pick on New York hospitals, but one of the things to realize is your financial condition isn't just because of what the third-party payers are doing. It's because of strategic choices that you make. And although they also, by the way, spend a lot of money, UVM Medical Center in 2024, subsidizes the medical school to the tune of about $35 million, in excess of the purchase of services. So that's a strategic choice. It may be absolutely necessary, but they are subsidizing the medical school, which is an add-on cost. And the year before it was about 25 million net subsidy. And every year it's been 20, 25, 30 million. So that's a strategic choice. It may be, again, something that has to happen, but it's something to think about. You're loading the cost of the medical school onto premium payers, onto the clinical system. And it's something to be aware of. The other thing UVM Health Network does is it invests in other hospitals outside of state. And let me just turn down the page. Okay, so if you took those Newark hospitals out of the system in 2023, just for example, how do the metrics look for the health network? So this column here is with the New York hospitals, and this column here is without the New York hospitals. And this is me just subtracting out the New York balance sheet and income statement from the system. And you can see that the New York hospitals make us have the system have a lower profit margin than they would have without them. On the whole profitability side, the network does much better without those New York hospitals than with. So when they come crying about their debt rating, which they got downgraded, and the Moody's and whoever it was, Fitch said, your operating profits are a little weak. They are weak when you look at them with the New York hospitals, but they're not so weak when you look at, they're almost 1.5%, 2% better when you look at them without the New York hospitals. And when you look at them with the New York hospitals, their days cash is lower than when they take them out. And the same for the debt burden, the same for debt service coverage, and the same for cash as relative to long-term debt. So that, when, yes, the New York hospitals might not be having their operating expenses directly paid by the network, but they're dragging down the credit rating. And that costs money in terms of interest expense. And if the network's going to use that as an excuse for why they should charge commercial payers more, I'm kind of going, well, maybe you shouldn't hold those hospitals. Then to go to the funds flow statement, because they sent out a fund.
Just go to the debt service coverage.
Yeah.
And talk about the differential there.
Okay,
Please.
so what the debt service coverage ratio is your cash generated from your operations. So it's your net income and add back interest expense and depreciation expense. And that's the cash you have available to meet basically your mortgage payment, your debt principal, and your interest expense. So with the New York hospitals, because they have some debt obligations and they also have some losses, that lowers your ability to meet your mortgage payment. When you take them out, you have much stronger cash flow from operations and relative to the debt.
Thank you. Okay.
So then you look at this funds flow thing that UVM sent over, because this is when I was helping Vermont Legal Aid understand this funds flow statement. And let me give you my understanding what they're saying. Okay, it's two key areas. First, they're saying UVM Health Network gains revenue, gains a net contribution margin over this 15 to 20, 7, 8 years of $272 million. And they're saying it's because New York residents are 15% of our revenue. So therefore they provide 15% of our provider tax and 15% of our related federal Medicaid match that the provider tax is used to generate it. Plus we have a contribution margin because their costs are less than their revenues, although that's dubious. So they're saying, over the 7 or 8 years, we are getting $272 million net benefit from having these New York residents coming to UVM Medical Center. This is
Can I ask a question right there? And I don't know whether this is possible to do, but this requires, if we're talking about having the New York hospitals in the network, if the hospitals were not in the network.
Well, okay, I hear you, and I'm going to come to that.
Okay, good. I won't ask it then. Go ahead.
So this is about the residents, not the hospitals. And this is saying we're getting these New York residents.
Thank you.
And then it says, and then meanwhile they say, and by the way, we're not putting that much money into those hospitals. Affiliation agreement cost us 10 million, health reforms 3.6, capital investment 7 million, and outstanding loans that we expect to have repaid someday, 69 million. So the total amount that we've sort of sent over there to New York is around 90 million, some of which we're going to get, most of which we expect to get back at some point. That's the argument for why they should have New York hospitals. And to your question, I think, was that you, Senator Lyons? One question is, do you lose these patients if you don't own these hospitals? And if you look at that bottom line there, if New York residents where would they go if they have a tertiary or quaternary need? They could go to, well, first of all, you guys are an hour and a half drive from Plattsburgh. I'm guessing that's the rough area. Albany Med is a 2.5 hour, 2 1/3 hour drive, and Dartmouth Hitchcock is a 2.5 hour drive. So even if you didn't own the hospitals, and I'm not sure whether owning the hospitals is the key here, where else would they go? And so that's one of the assumptions that you have to ask about whether that makes any sense. Would the Vermont patients, would New York patients not come if we didn't own those hospitals? Another is if the New York patients stopped coming, would there be enough Vermont patients to provide the same Medicaid, provider tax and Medicaid federal match that, the New York patients are currently paying? I don't know if there's a lot of backup waitlisting for Vermont patients, but I know at UMass we have way too many patients for the capacity that we have. And I guess, oh dear, the biggest assumption is, one of the biggest assumptions besides those other two, is that they're assuming, because New York patients are 15% of net revenue, that they're the same payer mix and case mix as all University of Vermont Medical Center patients, which is very unlikely, because that whole area is much poorer than Brattleboro. So more likely to be relatively more Medicaid, relatively less commercial. But again, that would be something you'd want to ask them. What's the payer mix of these New York residents? And, do we really have to, and would they go away if we didn't own these hospitals? So I didn't like their funds flow analysis, and this is why. And I also found it ironic that this is something that was reported in the Vermont Digger, which I guess is your local newspaper. Here you are, University of Vermont, cutting services in Vermont. And then I know they invested money in Alice Hyde to create a critical access hospital. So they're cutting money into Vermont and adding services and helping New York hospitals see more patients. Well, if they want New York patients to come to Vermont, why are they trying to make sure they stay in New York? It's just strategically, you're kind of going, what are they trying to? So that's just a little aside. So my takeaways, how am I doing on time? Okay, my takeaway is that the system survived one of the worst 3-year periods of operating results in industry history, doing almost pretty much as well as some of these other major academic health systems in the Northeast. They have made strategic choices that reduce their profitability and their liquidity. That includes the medical school net subsidies and financially supporting New York hospitals. They are, it looks like, underinvesting somewhat in capital expenditures in recent years, although I noticed in 2024 that CapEx to depreciation went up to 1.8. In other words, 180% of depreciation expense. So it looks like they're ramping back up. And they're still not so old that they go outside the norms for the creditors, Fitch type median ranges. And my final comment is that, I know you're asking for audits and more data, but there's a lot of data out there already on the financial side and on the cost side. Audited financials, unaudited quarterly reports, annual budget reports. There's a lot of financial data. What I think is often missing at the state level, in every state, not just Vermont, is the financial literacy to understand it, and the even bigger challenge is the political will to act on what you find.
That's why we're here.
And I helped the state of Massachusetts understand and then act on the Stewart disaster, but I started trying to do that. It took me years. It took years, because it takes a lot of political will to take on a health system that's serving low-income communities.
Oh, we like the last one because we're doing exactly that. We're using some of our political capital to invest in legislation that might fix the system as a whole rather than bits and pieces going forward. So your information is extremely helpful to us, and we greatly appreciate it. So we're going to ask questions, because there are a lot of questions. A lot of questions in here, and obviously we may be reaching back out to you for some clarification going forward. We certainly have our joint fiscal office an analyst who was in the room and will be with us going forward. We have our finance committee that is going to be helpful to us going forward. I guess the question overall, and the one that keeps coming up is of what value is an audit. What you said, there's a lot of data out there. You've provided us with a great deal and some suggestions for policy, policy recommendations. What a Green Mountain Care Board or an auditor contracted by the Green Mountain Care Board might look for. So just your overall assessment on the value of an audit going forward through the board process.
Well, I guess the question is, what are you looking for? And what do you want to audit?
Yes.
And I'm not sure. I mean, I look at the statements that I have already and I say I have questions. I'm not sure an auditor in general would know the answers to that without, I think the system can tell you the answers if they have to. You could say.
So one of the things that you mentioned early on was that an audit might lead to the link between changes in hospital budgeting or performance with commercial rates or with premiums. You talked a little bit about the link between the audit information and how to improve. I took it as premiums, but commercial investment, whatever.
So I think what I think you're referring to is my saying, if you have a high commercial payer mix,
Yes.
you might say, okay, you have a high commercial payer mix, so you're the one who's going to have the reference pricing, caps applied to your commercial rates. Whereas the guys who are, really suffering out there, who need every penny they can get, we're not going to cap them. An audit doesn't do anything to tell you what the payer mix is out there. You can get it. So you don't need an audit for that. The only thing, I mean, frankly, an audit would have been great in the Steward case because they were embezzling. But I don't think University of Vermont is embezzling. I mean, I think they're an honest place, but they leave kind of vague, or they give you these analyses where you go, well, what is the payer mix of your Vermont patients? And will they really not come if you don't own these hospitals? And how much did you spend on Hollis Hyde's critical access hospital? You need to know what questions to ask, but the data is out there to tell you to ask those questions. If that
have to go ask the patients, will they come to Vermont regard?
Exactly.
I got it. Yeah.
Don't
Okay.
build it, will they come?
Yeah.
So I think it's really an auditor, they will go in. I mean, I'm on the audit and compliance committee at UMass. I mean, they can get all kinds of data for you, but what are you going to do with it?
Yes.
And so my feeling is, I call this, don't go down the rabbit hole. Don't go down deep in an area of operational or financial activity that you don't know what to do with.
Yeah.
And so that's, I mean, I wrote my doctoral thesis on this in the 70s. I said, Massachusetts is trying to regulate unit prices, which is crazy. What you want to do is say, keep it at a certain level that's affordable, and patients are still coming out with the right outcomes. Focus on affordability, outcomes, and hospital system viability. And I think your legislation that I guess I just saw a copy of your outline of 2025, your bill is great. You're going to say, are you compliant with what the community needs? And then, you have people, like you can train a couple of people to do the kind of work I just did to say, are these hospitals sustainable? If they're sustainable, and then they say, well, we want to build a tower, $1 billion tower to attract patients from Canada to do liver transplants. You could say, no, it's not affordable and it's outside the health plan, and our community doesn't need it. So
what you're ending with is exactly where we're segueing. So we're going to be hearing from the Vermont program of VQHC healthcare improvement, looking at measurement, quality outcomes and measurement. So that's a nice segue. But I'm also hearing you say that from your quick look at the outline, the outline of the bill does include an audit. And so one of the reasons we're hearing you and listening to you is considering how and if to include audit information, and we will hear from our state auditor as well.
Yeah, I mean, if I were you, I would just make sure that the Green Mountain Care Board staff has someone who's very financially literate,
Yes.
doing financial work and come up with what you need
Yes.
to know for policymaking. I don't think you need to send them people out to the hospitals to look at their books.
Thank you for that.
That's
That's
amazing.
Yeah, I think what I hear you saying is that the information is there. We don't need to do another audit.
Right.
We need someone that can interpret that audit and then help us find out how we could reduce price, because we've been told we have the highest hospital charge per capita or in general in the country, which somebody pointed out to me means we have the highest in the world, since the United States has the highest. And we aren't that wealthy. So how do we cut through all the numbers?
Yeah.
And get rates that will allow people to afford insurance, because we've hit the point where your average family isn't going to be able to afford $44,000 a year.
Right.
Bottom line, which means your hospital's going to get more bad debt if people just stop going.
Well, they're
And
also going to get sicker.
yes,
Yes,
Mhm.
exactly. And so, the other question that I asked you about, can the audit connect in with the commercial payers, the rates, the premiums? When the budget is changed at the hospital level, can that be linked in with, that? You've answered my question. I get it. It's not linear. But we do need folks who can understand the data and interpret the data, as Senator Cummings just said, and that's important.
I just got an email, one of my regular emailers.
Okay, well, we're gonna not go there right now.
No,
Senator.
but it says they're cutting services here, the clinic, and they just announced plans to build a 10-story building.
Right,
How do you reconcile that?
yes, well, that's what we're after right now. It can't continue, I think. We do want to ensure that people are taken care of, but I did notice that the capital budget or capital pieces of the UVM network are old. I mean, as compared with others. So now investment in capital is something that might be important, but if it's balanced by removing services, what good is that? That's the question I think that you're hearing.
Yeah, I mean, it's what capital, the average age is saying they're actually in the average. It's just that their spending has been down the last 2 or 3 years because of their lack of cash, relatively lower cash flow. It's what they want to spend it on. So,
Yeah.
and what's their ambition? So it goes really to what's their core strategy? Is their core strategy to be a tertiary quaternary hospital for the world? That's an expensive strategy. Or is their core strategy really focus on Vermont and what, I don't know, what do you have, 500,000, 600,000 people? What do they need, and how do we make sure those needs are met? Now, if somehow a billionaire gives me $1 billion to do something that won't affect these people's pocketbook, go ahead. But don't make these.
You know what? Thank you. You know, what you just said resonates in this room, because do the budgetary changes respond to the state health plan, the state needs that our citizens have? And we can't do that without knowing, and we're working on that as well with one of our other pieces of legislation, but the bill itself will help us get several different places, all it's the same in different times. But it's a lot of work, and it means that we have to do a lot of things at the same time, not the least of which is to look at the cost. This is, we've got to do it. If we don't do it, we're at the edge of the cliff and we can't go over it. We need somebody pulling us back, and maybe the board will help pull us back. Senator, go ahead.
Thank you so much for that presentation. That was understandable, which is amazing because it's very complicated. But I do want to just draw a bright line under one of the things that you said, that this is really going to require political will, the likes of which maybe we've never seen before. So thank you for highlighting that. That's very important.
Appreciate it, much appreciate. And, you know,
Well-
every state is suffering, you know, especially the ones like Maine and Vermont that have a relatively lower income population against the ambitions of the medical enterprise. So we want to, you know, it's really, it's tough. It's tough.
Thank you. And thank you for being available to us. This has been terrific. I'm very pleased that we've been able to connect. And we will not lose that connection. So hopefully you can be with us. By Zoom. It's great. Appreciate
Okay,
it. Great.
well, thank you, Senator and senators and the committee. And we'll, you know, let me know if I can, if you want me to look at anything and give you feedback, I'm happy to do it.
Thank you so much. Terrific. So now, as is our usual process in here, we switch to a new topic, but it is not unrelated and it is part of what we have in the bill. And Hillary reached out, Hillary Wolfley reached out. Where is she? There you are. I feel behind. And
No, I'm just checking the clock. We're going to join, money chairs, so I'm gonna be like in order.
okay, well, we've got time for that. You'll be fine for that.
Really.
Hillary, why don't you come up?
I just do that 3 seconds.
Yeah, and you, I'm
Yeah.
thank you for reaching out, first of all, and VPQHC has always been something that I personally value greatly. And I'm pleased that you have reached out when you saw what was in the bill and you came to us. Was great that you're here.
Well, thank you for having us.
And I'm gonna ask you, do you know everyone around the table? And
I do not. I did just hear.
We're gonna introduce ourselves one more time.
Okay. I'm Ann Cummings. I represent Washington District and I chair finance in the afternoon.
I'm Senator Martine LaRocque. I'm in finance with Senator Cummings in the afternoon, so I got it all covered here. And
Along with education.
that's right.
I'm taking care of it all.
No worries. I live in Burlington and represent Winooski as of Burlington, a little bit of Colchester.
Nice to meet you.
I'm gonna turn you to Senator up on the screen.
Hello, I'm Senator Larry Hart from Orange County, home sick, so I don't get everybody sick there. I'm staying home. So
Thank you, Larry. Senator.
He's doing a good deed. And Senator Douglas is also out sick.
Okay.
And I'm Senator Jenny Lyons. I think that's for appreciate it.
Yes. Well, thank you so much for having us. My first order of business, I have no idea how to plug in my computer. And always come back.
Oh, yes.
So my name is Hillary Wolfley. I'm the executive director of VPQHC. My background is in public health and political science. And I've been with VPQ for 10 years and I just stepped into the executive director role this July. So about VPQHC, we're very old in nonprofit years. So we've been around since 1988 and were designated in 1989 by the legislature as an independent non-regulatory peer review committee. Vermont's 9416 statute established VPQ as a statewide quality organization in 1995. And our mission is to improve healthcare quality in Vermont by studying the system and making it work better. This is our fabulous team. We have about 15 FTEs, a really wonderful, highly skilled, passionate group that just makes the work come to life. Decades of experience, not only in healthcare quality, but also in direct healthcare service delivery and across the continuum of care. I have a few of my team members here who will be presenting on some of the project work that they do. And when they come up, they'll, provide their background and some information about the work that they do. But just a really wonderful team that we're fortunate to have. And in addition to that, we have a fabulous board of directors. We have Mike Fisher here, he is on our board. So we have patient advocates, mental health advocates, hospitals represented, insurers as well. Blue Cross is on our board, state agencies, the Department of Health, and Agency of Human Services. So a really great representative board that is really engaged with our work, and we're very thankful to have. So VPQHC funding, under the 9416 statute, we do receive build-back funding. It's about $660,000 per year. But per statute, that build-back cannot make up more than 75% of our total operating budget. So as you can see here, we have many other sources of funding. And currently, the build-back only makes up 29% of our total operating budget. Our other funding sources come from the state of Vermont, our non-9416 funding. So we have partnerships with the Department of Health and the Department of Mental Health, the Department of Corrections. We have direct federal funding as well, individual healthcare contracts, and we do have private philanthropic funding supporting our work as well. Something we are keeping an eye on are the federal funding streams that we have because of all of the
I get it.
yeah, all of that.
All of the
Yes. We're keeping an eye on it. It is concerning. Some of our work is tied to the CDC funding streams, to the Health Resources and Services Administration. So doing our best to keep up. There's not really much we can do. So before we jump into an overview of our project work, I just wanted to provide kind of a shared definition, common understanding of what we're talking about when we're talking about quality. So I've included a quote here from AHRQ that quality in healthcare means doing the right thing at the right time in the right way for the right person and having the best possible results. A lot of our work is, centered on quality improvement, which is a science. It means, changing processes and outcomes and realizing efficiencies in healthcare systems, using evidence-based methodologies and data, and really relies on continuous iterative improvements in testing.
Can I ask you a
Yes.
question? So one of the issues that's come up recently is that the ACO is closing its doors. But what is left are some mechanical, important quality metric data, and the data analysis that could be utilized somewhere for clinical improvement. So as you're talking, I don't know whether you're going to get to that and talking about how to integrate that work. But
I think we need to wrap our minds around it a little
That's
bit.
all
I think it's certainly something you'll see. We're just going to present on 3 of our projects.
okay,
You'll kind of see how we use data not only directly for clinical process improvement with providers, but also can produce outward facing, public reports on quality.
okay, thank you. I know the reports. I mean, I remember with Helen Reilly and Cy were there. We had
Oh, they were,
great work.
yes. Yes, we actually have that in the timeline that we, their recognition, I think some sort of recognition. Your name was on it. I found it in our office, but just thanking them for their work.
Yeah.
So yes, those types of reports. So quality, these are the 6 commonly recognized domains of healthcare quality. I'm not going to read all of this, but quality healthcare should be safe. It should be efficient, effective, timely, equitable, and patient-centered. So when we're talking about quality, we're really talking about across all of these domains. If you want to, reference this, we've included a really short definition. So like safety in healthcare means that when you receive care in, healthcare, it should not cause harm. For a patient, that might mean they feel confident knowing the care team followed the right steps to check their condition and keep them safe. So we kind of worked through each domain and have a quick definition, then what it means for the patient experience. So, we're championing quality and the focus on quality. I know there has been a real emphasis on access and cost recently, which makes a lot of sense. But for a well-functioning healthcare system, you really need all three. You need access, cost, and quality. Something that was concerning to us was that Act 167 report where quality is only mentioned 15 times and access is mentioned almost 100 times and cost is, over 100 times. So
quality was at the top.
Quality, okay, yeah. Maybe we can feel better about that. But, we appreciated the positioning. But just we think it's really important that not get lost in the conversation, especially when you're making recommendations on healthcare system reform, that it's really seriously considered and analyzed what the impact, will be to quality and patient safety if services are changing. So I mentioned briefly that we're old. I did include, actually, I'll just bring that up quickly. A handout with all of our work dating back to 1988. I'm not going to go through that. You can read that if you'd like, but it kind of gives you an idea of the topics and areas that we've addressed since we were founded, bringing us to 2025. I only listed 17. We actually have 18 projects right now that are current. And I've included those in that handout. We don't have time to go through each of them. They could each be their own presentation. But just for your reference, this handout includes the name of the initiative, who the funder is, and a very quick description. But we're working, our work spans partnering with the Department of Corrections on morbidity and mortality reviews to look at clinical quality, to partnering with all the Vermont hospitals on suicide prevention best practices. We've been doing that for 3 years, actually, and that's been an outstanding project. So I just have to give the hospitals a little credit from our perspective. They're continually coming to the table to work on non-required voluntary quality improvement initiatives with us, and the suicide prevention project is just one of them. So if you want to go through all of these, you are welcome, but
it's a lot.
It's a lot.
Yeah.
For 14 people. We're definitely a lean organization. And then at the bottom, we've included some of our more recent reports and resources. We've hyperlinked them. So if you click the image, we'll bring you through to the reports. We recently had a presenter on CMS hospital star ratings. It has some really interesting data, Vermont data, but also national data. I know that that's come up in the conversations recently, so that might be of interest to you. So yeah, we move away from that. Yep, I think I covered that. Okay, so we are going to highlight 3 projects today and go a little bit more into detail, and I'm not going to present on them. The project lead is going to present on them, and we are focused on one hospital-based initiative, one in partnership with primary care, and a third in partnership with independent mental health providers. So
Do you want to be up together?
I think we can just do some
Okay,
musical
that's
chair.
fine.
Yeah, that's fine.
Good morning. Thank you so much for the invitation. My name is Patrice Knapp. I am a master's prepared registered nurse. I have been nursing since 1979. And I'm old enough now to be a consultant. So I have worked for VPQHC in the past as the quality director, and most recently as a quality director at CVMC for about 8 years, and then transitioned to VPQHC. And my role I have a few roles within the organization, but mostly advice, guidance, and mentoring. I've been asked to just familiarize you with the Vermont Patient Safety Surveillance Improvement System, which is a mouthful. We call it the PSSIS. And what this is a system that we're subcontracted from the Vermont Department of Health to receive serious reportable events and have a systematic process of reviewing the causal analysis that the hospital is required to do within 60 days of reporting. And, you know, that involves really reading and following the story and looking at the corrective action plans for feasibility, for sustainability, and for systematic focus. You know, a corrective action plan that only says retrain people, it doesn't fly. You know, we push back and we give them evidence-based strategies. We coach them, and you know, before it's all finalized and sent to VDH, we make sure it's polished and packaged, and that they are committed to sustaining it. And the way that we check on that is we have periodic site visits. And in the last 2 years, I've visited all of the hospitals myself, along with another colleague from UQHC. So what that is doing is it's supporting a trusting relationship. And, you know, this is sensitive information. And they're very, very open to being transparent with us, because I think our reputation precedes us by many years. And, you know, because I've been one of them, that's very helpful. And my colleague at VPQHC has also been one of them too, in a quality director role. So we're finding really good engagement, and people call us on a daily basis, asking us questions, looking for guidance. And what we do is we bring them together every quarter for a quality directors meeting, and patient safety is always on the agenda. And we gleaned from those corrective action plans topics of interest and disseminate best practice as well as innovative practice that a hospital has decided we're going to try it this way. You'll see on the right-hand side, the numbers have gone up over the last 5 years. That's not surprising. It's a nationwide trend. Most of ours are pressure injuries, hospital-acquired pressure injuries that advance to a stage of needing treatment. So much work has been done on pressure injury prevention. We're still kind of plagued with the numbers continuing to go up. There are many contributory factors, especially the workforce. You know, we have brand new grads, and we have less. All our vacancies are not being filled. It's just harder to keep people turned and off of their tissues. You know, often enough in a 24-hour period. And that's where hospital-acquired pressure injuries originate. So they're working very, very hard on that. You are familiar with our annual report, and that's a safety report that can be found every May is when it is published.
Question. What is pressure injury?
People used to call it a bed sore. So when you're on a surface that is not supportive or flexible enough, soft enough, or if you have not turned your body, and many people are very, very sick in the hospital, and they need help turning their bodies, or they refuse to turn because it hurts too much. And then you have a pain control issue, which is really where we should be. We should not make turning painful, but it's a balance. Sometimes you can't give people the amount of pain medication.
And these injuries are part of what's driving those numbers up?
Absolutely. And to a lesser measure, falls with serious injury. But serious injury is a fracture. So it can be a fracture of your thumb and still be serious reportable. So it's a little bit hard to gauge that without looking at the nuances. So that's what
We'll keep going. And this is the tip of the iceberg for us. So I'm going to give you ask you a question at the end, all of you. But
okay. All right.
Great.
Well, I will
Thank
let
you.
my colleagues take over.
Yeah, I think so. This is great. I know you started out, I guess BPQ started out a great deal with children's asthma and asthma overall. He's moved on.
So, thank you for having us here today. So I'm Randall Messier. I was originally trained as a medical technologist and I ran the hematology lab and taught hematology at the Medical Center Hospital, Vermont, many, many years ago. I have a master's in science administration and with that, I became the director of primary care, internal medicine and family medicine at the medical center for several years. I brought all my clinics through NCQA medical home recognition using quality improvement and decided that was so much more fun. That I left the world of administration and primary care and started teaching healthcare quality improvement at the Dartmouth Institute and then at the University of New Hampshire. I've also taught and worked with healthcare systems in Australia, Saudi Arabia, Sweden, and England. I live in Fairfield, so the internet's been a wonderful thing for me to be able to connect with those. I'm also a certified content expert from medical homes from the NCQA, and I have my certificate in value-based care from the Dartmouth Institute. And I'm old enough to be a consultant as well in that process. What my role is at VPQHC, and I've been there for a couple of years. I joined on the day of the flood. My first task was to remove rugs from the building that were soaked in water. I came in like a wrecking ball. My focus really has been in primary care and some of the community-based services. I've done a lot of work. I've written on integrating behavioral health in primary care. I've written a lot on measurement in chapters and books on that topic. So my love is in primary care and measurement and evaluation. And so we have an example here of our support of a primary care pediatric clinic where we work with these centers to implement, operationalize, and measure what they're doing is actually an improvement. So this was work with a pediatric practice based on the Blueprint expansion funding they had to implement a health-related social needs screening. You know, how are we doing? Do we understand what our patients' needs are? We help them implement that process, create a procedure to get the information back to the provider, because if they don't know it, they can't adjust the care plan accordingly to make that happen. And also ways to measure it to see, are we making a difference? So in this situation, we implemented the health-related social needs screening tool. And this was a Franklin County community I've grown up in, looking at the health-related social needs and their St. Albans and Enosburg practices, which people say, oh, it should be a surprise. But the information we're getting from the state, we're saying that housing and food were not a problem. When you look at where that data source came from, it's because it's only collected at the hospital. And the biggest problem was living alone in old age. Why? Because there were older people in the hospital. When we look at our own data, we found out, no, this is a pediatric practice and housing and food is a huge issue, of course, transportation and then safety, which was a surprise to them. We asked the providers, what keeps you up at night? And they said, patients that we're not seeing. If we're not seeing them, we can't help them. So we said, well, what are their health-related social needs? And when you take a look at the chart on the right, you can see that by multiples, percentage-wise, their needs for housing, food, transportation, and safety were higher. So we're saying, patients, you're non-compliant. Why aren't you coming in? It's because I'm more concerned about where I'm going to sleep tonight, what I'm going to eat. I can't get there, and am I going to be safe? So unless you address those, you're not going to help the patient. So we implemented a community health worker program with that group, not just here's someone to help you. We have procedures and protocols that we put in place to say, here's how you're going to interact with the patients. But we also want to make sure that it was cost effective. This is a non-billable service, so we're adding an expense to the system. If you're adding an expense to the system, you better know what the improvement is.
The outcome is going to be benefit.
The outcome has to be a benefit. So I always look for clinical, operational, and financial measures because there's something in there for everybody. Because if it's not clinically relevant, why are we doing it? If we can't financially sustain it, why do we not do it? And operationally, if you can't do it cost effectively and create the outcome you want, why would you want to do that? And that's not my method. That's CJP, University of Minnesota's methodology, but it worked well in that process. So we did that evaluation and tried looking at the number of encounters and the cost per encounter. And you can see we implemented this between Q3 and Q4 and 23. And there was initial uptick because you're establishing a program, but as you can see, we started seeing more patients, and then our cost for each one of those, of course, goes down because we're seeing more without increasing the cost of the system. But what we were doing is decreasing costs. So one things we like to do, and this is just one of the stories you can see on the right, was because we have this community health worker in our practice, we were able to intercede in a situation. Yes, ma'am.
Are we talking blueprint practice here?
This is a practice that's supported by the blueprint.
Yes,
This was a
I'm
blueprint
gonna ask you a
expansion.
question later, so keep going.
Yes, not a problem. So in this group, this was a woman whose baby required services. They had one car which is not operational. They couldn't get a taxi, they couldn't get anything. So in the past, they called the ambulance who brought them to the ER. Why? They will come. You know they're going to drop you off ER. It's the only place they can bring you. And there you go. But the community health worker, they had her number. They called her and said, what do we do? She talked with the physician. And in this practice, they said, you can go pick her up. So they went to the house, picked up the mother and child, brought them to the clinic, and provided the care. You can see here the cost savings of the expense to the system was less than $2,000. Now, the service that baby needed could have been provided in the ER for $1,500, or we provided it for $60 in the clinic. But because of their health-related social needs, they weren't able to access us. So they were going to go get the way they needed to get the care, which was the ambulance and the ER, and those charges and expenses are much more for the same quality of care and level of care the patient needed that they could get in primary care, but we couldn't get them there. So this program did that. Now, with the expansion funding ending in June, this program is going to end along with that. But this is just one example. I work with this group to collect stories around this, like, because if you can't prove that it's working, we should stop, because you need to have the information to show. But this was just one example, and they have many, but I just wanted one to share.
Why is the program ending in June?
I think it's not included in next year's budget, the expansion program for that's the community health worker here. These are non-billable services.
Yeah.
The community health worker is funded by that money from the expansion. And when that money ends, this clinic doesn't have the capacity because it's a pediatric primary care practice with little to no margins.
So what I'm going to go with this is, well, we're going to have to take testimony in here and make recommendations for next year's budget, and then I can carry it down to the hall. So my question of you, two things. One, you identified the need for sort of that community connection and transportation available, et cetera, et cetera. That's exactly the type of planning that's going on right now with Act 167. So you're reinforcing the need for the work that's going on. Thank you for that. I think we all get that. The other question I have for you is, you've got blueprint data here that indicates savings and access and quality.
Yes.
And did the auditor reach out to you when the auditor did his report on the blueprint to demonstrate savings for blueprint? Because it came out and said they didn't have the data to demonstrate savings. So now I'm questioning, were you included in that audit?
No.
Ooh. So maybe you should be.
Well, I think there are ways with standard methodologies to evaluate a program. What the difficulty issue is, me starting this with this group, one of the things I do right up front is set it in measures. So if we're going to do this, how are we going to evaluate whether it works or not? It's harder for people that do that to then go back in to prove what happened. You can, but
the data is right here. So anyway, thank you.
You're very welcome.
This is great. We've opened up a lot of new doors and little rabbit holes that we can now proceed.
What's the story?
That's right.
It's an awkward
Be careful of our Blue Cross. Welcome.
Thank you. Thanks for having us. My name is Mary McQuiggan. I'm the Director of Programs at BPQHC. I'm a licensed independent clinical social worker. So my background is in social work. I worked in inpatient psychiatry and for several years as a high school social worker before starting at BPQHC. And actually, Randy story made me think back to my social work days, because a lot of what I did was helping kids get to appointments, get to therapy appointments, get to doctor's appointments. That transportation piece is so huge. But so the social work lens is what I bring to all of my work at BPQHC. And I'm going to tell you about a project called the Vermont CAMS Training Project. And CAMS stands for Collaborative Assessment and Management of Suicidality. And it's a treatment modality for treating people who are experiencing suicidal thoughts. So with this project, we wanted to increase the quality of care provided to individuals experiencing suicidal thoughts. So we started with a survey. We thought it was possible that there were mental health clinicians across the state who would be interested in and could benefit from more training related to treating people with suicidal thoughts. And we asked a lot of questions. I showed 2 of them here, but we found that 60% of people who completed the survey said that they had not engaged in any training specific to treating suicidal thoughts for treatment. So they hadn't had any training specific to that, specific to treatment. And then we also asked people, do you want more training? And 82% said yes. So for us, that was pretty clear that this was something people would benefit from. So we partnered with the Four Pines Fund. This was supported through philanthropy. And we had three main goals. We wanted to offer this evidence-based training to clinicians across the state, and we focused on folks outside of the designated agencies because we knew that the designated agencies were getting support for this through the Department of Mental Health and the Center for Health and Learning. They were providing these CAMS trainings in the designated agencies when we started this project. So we were focusing on people outside of those, that we then grew to just really be open to everyone participating. So you can see here how many people we trained, 428 in this sort of baseline level of training. We also wanted to build a community of practice so that clinicians who get this training also feel supported, so that when they're out in the field supporting their clients, they also feel like there are people who they can go to for more support. So we do that through our community of practice. We meet quarterly and bring experts in from CAMS to provide expert consultation. And then the third thing we wanted to do was to create a list of folks who have this training so that we can support referral resources. So if somebody needs a mental health clinician who have this training, they can look on our website and find folks who've been trained in it. And there are ways we still want that to grow and make that more user friendly, but that's been our goal. And those have been our sort of 3 goals with this project. And we've gotten really great feedback from participants. And yeah, happy to answer any questions about that later.
So, maybe you could talk about who you're linked in with a little bit in terms of the Department of Mental Health or some of the community services.
Yeah, so this is because it's private funding, we definitely we're coordinating with Department of Mental Health. So like we work on a lot of projects with DMH and VDH around suicide prevention. Yeah. So we work closely with Chris Allen and Nick Nichols. So we sort of work parallel on this project specifically, I would say. Yeah.
And then community services.
Yeah, so we've also, I'd say we connect with community services more through some of our other projects, like we do one project we've been working on with VDH is around educating people about suicide safer care and using telehealth. So this is also for mental health clinicians. We have a webinar coming up that we've run a couple years in a row where we bring in folks from all different organizations in the state where so that mental health clinicians who have a patient who needs support, they'll know what those community resources are. One thing we've been finding is that with telehealth, there are more providers available, but there are a lot of providers from out of state who don't know what the resources are within the state. Yeah,
it makes a big difference.
Yeah.
Thank you. This is
right. I'm going to breeze through 2 more slides and then we'll be done.
Excellent.
I don't know how to follow this, but
Right on
let's see, what did I say?
This is
Oh.
good.
So looking to the future, we are going through a strategic planning process. We started this back in the fall with our board and the VPQ staff. We're going to be forming up, it's going to be a 5-year strategic plan. So I just included a little snapshot here of our updated mission
Mission
statement.
process.
Yeah, it's been a great collaborative and actually fun. I can say that process. You can't always say that about strategic planning, but we have a great facilitator. So this will hopefully be finished in April, and we'll be sending that out to other stakeholders for their input and feedback before finalizing. And so VPQHC, just in summary, is uniquely positioned to work on statewide healthcare quality initiatives. We're a trusted, neutral convener. We have a collaborative funding model, which we were forced out to find funding, but I think that actually benefits our work because we're not forced. We would do it anyways, but we partner with, agencies and different organizations on all of our projects. We have a statewide reach, data-driven, and really can be responsive to Vermont-focused priorities because we're not tied to, maybe a federal funding model that the priorities are set at the federal level that then need to be carried out and try to fit into the Vermont landscape. So just please thank you for your work. Please continue to prioritize quality in the healthcare reform discussions. And just remember that we are a resource to you in this work as you move forward. And if you ever have questions about quality, we are here for you. So
You just said you were a resource to us. Which is
but
what you're saying here. No, but thinking about the framework of legislation, the committee bill that we're looking at in here, one of the elements of that is looking at clinical data and how to utilize it effectively for quality improvement. And then how does the ACO the mechanics and everything that's going on in ACOs, we don't want to lose it.
Yeah.
So my request of you, if you could, is to think about two things. One, what role might you play in the legislation that's going forward, in the work that's going forward? That's one. What role? And that's part 3 of the bill, which talks about vital and the data and everything, EMR. That area in particular, but more broadly than that, the healthcare planning, the quality, what kind of data and what should we be looking at? So what involvement, if any, would you suggest for VPQHC? Not to put you on the spot, but to think about that as you leave, and you can come back and or let us know, and that would be really helpful. So a couple things. Yeah. One, the bill as a whole, the vital piece, and I mean the EMR piece, but then ACO quality piece. Mm-hmm. I don't know how that fits all together. And you've got people on your board who might be able to advise with that.
Okay, great. And what bill is this? Is it
exactly? Don't know what bill it is. Kiki will send you a copy of. It's a framework. It's not a real bill.
Okay. All right.
Developing it. It's in the process right here.
Okay, right. Great. Yeah, we'll take a look at that and get back to you. We'll take a look at it with the team and share our thoughts.
That'd be good. I would like to include you somewhere in the bill because I think what you offer is significant and it will help inform a lot of the work that people will be doing.
Well, thank you. And thank you for the time today. We really appreciate it.
Oh, no, it's great. Thank you. Thank you for your time.
Let's see how.
So,
okay,
we're good.
Thank you.
Thank you.
Thank you very much.
Thank you.
And I know you don't remember me, but when I first consulting jobs was working with Helen Real and Cy Jordan at the VPQHC. When I left, I worked with it and I worked with
I vaguely remember that. That's great. That's good. Thank you.
I'm a retread.
Thank you for staying connected. That's awesome.
Yeah,
Everybody knows everybody.
Yeah,
This is good.
Yeah, it's good to see you. I know. I was
So we have some folks in, today, and, when you come back, Senator, I'm gonna take a break too.
Okay, I'll be right back.
Yeah, we're just gonna rotate.
I'm gonna leave in about 2 minutes.
Yeah, that's right. So I'm actually looking for Troy Hickman
That's me.
of the, oh, here, okay, good. Troy Hickman here?
Yeah.
Here you are. So I'm just gonna share with everyone as everyone's getting settled and organized. And Susan Still is here. They're here. We have very limited time. So we welcome you. We'll listen to you for 4-5 minutes.
Okay.
And then we're gonna move on to Commissioner Levine, and then we're going to, and his group, and then we're going to move on to the last group on the stage, which is Mike Duto. There you are.
Can I do my apologies beforehand? I have a money chairs meeting and I have to leave at powder.
Senator, and we've got folks up on the screen, up on Zoom today who are out sick. Everybody is listening. This is good.
Very good.
So welcome.
Thank you so much. My name is Troy Hickman. I'm with the Vermont Arts Council. And so I'll do less talking and give Susan and Ashley just a bit of time as well. But I'm here today as part of the Vermont Creative Network Sector Day. And we're getting into a lot of committees and talking about the strength of the creative sector and the industry, which is a $1.2 billion industry in Vermont. But also just as important is that our work strengthens our communities, brings people together, and of course builds our economy. So I just wanted to just take a minute to just mention our creative aging work. Over the past 4 years, we've developed with state and national partners a process for delivering grants to the community around creative aging, and also training teaching artists to go into those communities to do that work. And so over the past 4 years, we've funded more than 20 organizations in communities such as Bennington, Brattleboro, Guilford, White River Junction, Saxton's River, Roxbury, Burlington, Winooski, Hyde Park, St. Johnsbury, Island Pond. So we're getting into some rural spaces, and we're bringing teaching artists into those spaces to do some great creative programming. And key to this work is social engagement. So we were very fortunate to contribute to the state plan on aging and identify, have the arts included in that social engagement piece. And also in the highlights report of year one that just came out from that work with Department of Aging and Independent Living, that were highlighted with our grant program and our training for teaching arts. So at this point, I'll just turn it over to Susan so she can kind of just make it, more vivid for you all what happens in those spaces.
Great. Thank you. This is terrific. Susan, go right ahead. Whoop, your screen left. Your slides left. Your slide deck is gone.
Okay, I'm going to start talking while I find that again. There we go. I'm Susan Still. I'm 75 years old and I'm aging creatively in the little town of Saxton's River in Windham County. I'm aging creatively by serving on the board of directors of Main Street Arts. And our mission is related to healthcare. It is to strengthen personal and community well-being through diverse arts experiences and social connection. One of the ways that we do this is starting with our weekly free lunches on Tuesdays. And these are for anybody over 60. Even though we are in a town of less than 500 people, we draw 32 people on average every week. And this is paid for by Senior Solutions, the Southeast Vermont Council on Aging. What happens is that we schedule our creative aging classes before and after the lunch, as well as other times during the week. But this allows a very organic way for people who are taking Tai Chi or printmaking before lunch to hang out and meet more people who are there for lunch. If you are then invited to stay for theater games after lunch, you've already built some trust and relationships over lunch and are going to be more likely to have the trust to try something try something new. One of the things that we've done is to tap our elders themselves. People complain about too many old people in Vermont. And we found that actually they are great assets. Old people have had exciting life experiences. So taking the idea from TED Talks, we do 20-minute talks that anybody can volunteer who's older to talk about their life experiences. And this has spurred a lot of exciting conversations. Here's a little bit about our creative aging classes. I'm trying to keep things very short here, so I'm going to turn it over to Ashley to tell you more about, are we out?
That was me just unmuting.
You've got about 1 minute, sorry.
Sure, I will be very brief. I'm Ashley Starrow, the program director, and I'll just highlight some of our classes. So we have 6 different creative aging classes. We have 7 highly qualified teaching artists, and this is all funded through the Vermont Arts Council. Vermont Arts Council are making these classes possible, and we try to reach around 80 adults. These classes are free, and therefore we're accessing a wide range of individuals through these classes.
Great, thanks, Ashley.
Yeah, are we out of time? We just have one more.
Yeah, we are pretty much out of time. I need to.
No worries. Well, thank you so much. We deeply appreciate the time.
Thank you to you all, and we'll be in the card room at 3:30 today. There will be a circus performance, so I hope you all can join us for some cookies and some fun. So thank you all.
Will do. And yeah, I think Dr. Bean is next.
Thank you.
Thank you. See you at 3.
Thank you.
Mark Levine, Commissioner of Health. This is a brief bit of good news testimony, I call it.
Yay.
And the topic is farm to early childhood education. Many of the issues which policymakers struggle with, from educational achievement gaps to deepening disparities, have their roots in how well a child is nourished and nurtured during the first years of their life. Those who've heard me speak before know my fondness for discussing children's brain development as well as their physical development, and these are directly linked to high quality nutrition. And the most critical years are, of course, those first several years of life when we're talking about shaping the brain's ultimate structure and capacity. So there are really 3 factors that influence early brain development. One is reduction of toxic stress and presence of strong social supports. Another is secure attachment. And the third is nutrition. These are not in any order. It's nice to have all 3 concurrently. And children need access to healthy foods. And some are at risk due to their family's nutrition insecurity. So if 2 in 5 Vermonters are experiencing food insecurity as they are now, you can imagine that such families may have difficulty having their children be free of food insecurity. Add to that the fact that almost 3/4 of Vermont's children under 6 live in households where parents are working. All parents. That means that these children need childcare during the work week. And childcare programs have now, of course, become the place where children can receive lunch, sometimes breakfast, every day, and often more than half of their daily calories. So it's even more important that they receive nutritious meals no matter where they are. And farm to early childhood programs ensure that while also supporting Vermont farmers. So I'll just discuss a few moments of how farm to early childhood programs can help. First of all, they can bring local foods to children in childcare programs, giving children an early chance to taste new fruits and vegetables. This is an early exposure to fruits and vegetables, which helps children build healthy habits and learn more about how a variety of produce can help them grow. We also know that children let their parents know what they may have tried, and if there are new foods they may have tried that they like. So that encourages the parents to provide foods like them at home. They also get nutrition education, often experientially, because many childcare programs have gardens that children can help tend and eat from. Children can be involved with age-appropriate food preparation tasks while in their early childhood program. And we know that children that have grown and prepared food are more likely to try it. So those are very, very powerful factors that kind of can happen very naturally. Also, these programs provide opportunities for our Vermont farmers. So the whole local VOR movement, selling products locally to the child care programs. And they build awareness for families that the farms are nearby and can produce and can provide produce and other products for their use at home. So in sum, the Farm to Early Childhood supports high quality childcare, nutrition security, and access educational opportunities for children to shape their habits and preferences, which can last, of course, a lifetime. And they support local farms in supplying food to the early childhood programs. And there are funding opportunities available to help them create robust farm to early childhood programs, which I think you're going to discuss. So I'll just name the ones that we kind of count on: farm to school and early childhood capacity building grants, and CSA grants, community supported agriculture, which all accomplish the same 4 goals I just mentioned. So I will turn it over to Steve.
Before you leave, we're gonna count that this will not be the last time that you're before our committee. I thought.
No.
Well, okay.
Unless you don't want to.
Don't want to lose one.
Unless you don't want to hear my budget or.
No, we do want to hear that. So that's good. I just want to make sure. I just want to make sure. Okay.
Wonderful. Well, I'm Gina Clitheroe.
Come right up. This is great.
I'm with the Vermont Agency of Agriculture, Food and Markets. I manage our farm to school and early childhood grant program along with our other farm to institution programming. And I'd love to just pass these reports out. I'm not sure if we could take one.
We can leave one. But there are people who are sick.
Yeah.
And then one who adds the emergency board.
Perfect.
For some meeting.
Well, I'll keep my comments really short because I'd love for Beth, who's an early child care provider on the line, who's one of the grant recipients of this program, to be able to speak. But this program, this grant impact report that you're reading gives a nice overview of what the program does and how it's reached a statewide audience. The program we started in 2006, funded by the Rosa McLaughlin Act. And we currently are putting out $500,000 each year to schools and early child care programs to support them in doing the type of programming that Dr. Levine spoke about. So getting local food in the classroom, helping kids learn about agriculture and food systems and nature. And it's having an impact on farmers and also on nutrition and quality education. So I want to keep my comments really brief because I'd love for Beth to be able to speak.
I'm going to say one thing. I'm going to say one thing. I don't usually talk about what I did here, what historically, but my first term here, I was vice chair of agriculture, and we invited, well, I can't remember her name, but she came in from the Agency of Agriculture, and Senator Cattell led us in a discussion about how we can improve farm to school, orchard to school, and improve the program. And so it was just like a baby. Now you're taking it.
And now Vermont is a leader across the country.
It's amazing. Terrific work.
Yeah.
So we'll hear from next week.
Thank you so much.
Yeah.
You're on.
Go for it, Beth.
Great. Okay. Thank you so much. Good morning. My name's Beth Traver Adolphus, and I'm the Executive Director of Oak Hill Children's Center in Pownell, a high-quality early childhood education program serving children ages 6 weeks old to 12 years year-round in our rural low-income community. Thank you so much for the opportunity to speak to you today about the importance of farm to school and early childhood, and to ask that you please support the Farm to School and Early Childhood Grants Program with level funding base appropriation of $500,000 for fiscal year 2026, as well as the local food incentive program for schools at $500,000 level funding base appropriation. And to provide a little background about our center, we participate in the Child and Adult Care Food Program, or CACFP. Almost 80% of the children in our community are eligible for free or reduced lunch, and every Vermont family at our center receives childcare subsidy. Food and nutrition insecurity is not uncommon, and a number of our children have experienced trauma. The nutritious home-cooked breakfast, lunches, and snacks we provide our children daily are critical to combat these challenges and support optimal health and brain development. We know that good nutrition has a direct effect on child outcomes. Our Farm to School and Early Childhood program is a cornerstone of our work, and the grant funding we've received has allowed us to create a many-layered program that supports children, families, local farms, and the community. The children at our center are living proof that children are far more likely to try new healthy foods if they have a hand in growing and or preparing it. With grant funding last year, we were able to build a 288 square foot, we were able to build 288 square feet of new raised bed gardens. Children and families were involved in preparing the beds, in planting, in maintaining the garden, and harvesting. And one of the items we grew was broccoli, and over one very warm weekend, the heads got a little leggy. Since our broccoli did not look like store broccoli with the beautiful domes, we didn't think the children would eat it. We decided to send it out to the classrooms anyway, so they could dissect it and learn about plant parts. Not long after that, our school-age educators contacted me to say that the children had eaten the entire head and were looking for more. Our preschool pre-K children regularly make hummus, which they refuse to try before they made it themselves. And beet is their favorite. I think it's because it's bright pink. But they also make fruit smoothies, which do not contain added sugar. The first time they made it, our educators were surprised by how sour it was, and they were sure the children would reject it. The children drank glass after glass. Along with more traditional vegetables, our children grew and enjoyed many foods that were new to them: spaghetti squash, delicata squash, pickled onions, and pesto pizza, which was made with fresh basil from our garden. They also share their excitement with their own families. We were able to grow enough produce that we could share with families, and you could often hear a parent and child discussing how they wanted to prepare their zucchini if it didn't get eaten on the way home. Funding also helped us to hold fun educational events like Pumpkin Palooza and Farm Day, where families could learn from farmers about their animals like cows, goats, chickens, and bees, try seed planting, make quick pickles, play plant parts, matching games, and more. Our harvest dinner provides families and staff an opportunity to prepare and eat a meal together using the harvest of the month. Our monthly Breakfast Buddies program, which frequently features local food, gives families the opportunity to share a meal with their child in the classroom. All these initiatives create important social connections between families, exposes them to local farms and local food, and are supported by Farm to School and Early Childhood funding. A community-supported agriculture grant has allowed us to purchase all of our honey, maple syrup, and nearly all of our meat from farms less than 2 miles away. A Farm to School and Early Childhood infrastructure grant provided funds for a new freezer, which allows us to preserve our harvest and safely store a few months' supply of local meat. There are few investments that can create such broad and lasting impact, not just for each of our children, but for their families, our farmers, and our communities. The results are lifelong. Again, I respectfully ask for your support for the Farm to School and Early Childhood Grants Program with level funding base appropriation of $500,000 for fiscal year 2026, as well as the local food incentive program for schools at $500,000 level funding base appropriation. Farm to School and Early Childhood dollars go a long way. Thank you so much for listening, and also thank you for the Zoom option, because the flu season's not been kind to me either.
Well, thank you for your time, and thank you for all of the, I love all the pictures that came with your presentation. It's great to see, and thank you for your work. Terrific.
Thank you.
And you got to jump on the budget. We do take testimony from time to time in here on the budget, so you're ahead of the game. It's good. Sure.
Thank you. I don't know who this should be addressed to, but I did have a question about how an organization, and maybe it's in here, but how they access the grants and the money, and also is there a connection to the organization need, is it need-based?
So can we do that offline? Can we do that after we hear the last
Sure.
person? Because
You
I might
bet.
also have Mike to tell you.
Whatever works.
Yeah, I'm happy to like send you an email
Okay.
response to that
Yeah.
question. That would be helpful.
It's a good question.
Yeah.
Who's next? All right, come right up, please.
Thank you so much.
Thank you.
Thank you.
That's it. Okay, we're good.
And there's a school lunch for lunch in the cafeteria, taco bar.
Oh, good, I need it. We've all go good.
Thank you.
So now,
Apologize. My water bottle.
oh, don't do that. So Mike, why don't you come on up? And, you know, we've got like 5 minutes.
I won't need all
This
5
is life in the
minutes.
legislature.
No, I-
Thank you for waiting and being patient.
Of course, thank you for the opportunity again. My name is Mike Tito. I'm a pharmacist. I'm here today representing the Vermont Association of Chain Drugstores. Really, today is more of a conversation than a presentation. I just wanted to take the opportunity to thank you again for your strong support of pharmacy and, as importantly, our patients. Pharmacy is a challenging environment right now, so I'm here today to reaffirm our commitment to maintain patient access to pharmacy and pharmacist services. We are working very closely with the Board of Pharmacy and OPR. Both Carrie and Deputy Hibbert are an asset to the professions and the state. We're very excited with the work that's being done. And again, we just really appreciate the support.
Wow. Thank you. That makes us feel really good. And we had some testimony from a pharmacist who is doing more direct patient care and work. And I'm hoping that we'll be able to move some of her suggestions along a little bit at some point. I'm aware in what bill, but somehow.
We're very supportive of more direct patient care.
Yeah.
You know, pharmacists practicing at the top of their profession really does allow expanded access. It's not just about the physical pharmacy. It's about the services that we can provide from within. So on behalf of all pharmacists in Vermont, we really do appreciate your support.
Oh, it makes us feel good. Thank you.
Thank you.
Thank you for doing that. What a way to end the day.
Have a great day.